Good afternoon. You guys are early. Feel free to, get up and do things before we start. Who are your class representatives?
That is Tom and Morgan.
Okay, thank you.
Mhm.
So what's new? Did you guys have your first sim? How'd it go?
It wasn't too bad.
Good.
Just doing paperwork and Nanda's now.
Oh, for clinical, for the VSIM? Yeah. Did you have sim for lab yet with Ms. Arnold? Yeah, you also had that.
Oh.
Wow, you guys are just moving right along, huh? How many
Yeah.
weeks of clinical are you in? Your third week of clinical. Good. Trevor, is your video working?
Yeah, I'm just waiting till 2.
Okay.
Trying to finish my fruit snacks before class.
Yeah, the other ones who got here at 10 to, I told them they could, do the same. But they're not. They're sitting here anxiously excited to start class. Sometimes it's 2 o'clock class. It's like we're waiting all afternoon. It's like, can we just hurry up and
Yeah, 4-hour break in between classes can be pretty rough.
So what is your schedule like on Tuesday? I have it, but I don't have it memorized yet.
We have nursing 111 from 8 to 9, and then we have pharmacology from 10 to 11, and then we have a break up until 2 for your class.
Huh. Do you like study during that time? Do you have like does it work for you? Sometimes it can work if you feel like, that's your designated study time and you're just in school mode. You can kind of get going on those morning classes and get stuff done, prepare for this class.
So I get like a lot of homework and ticket and assignments done and things like that. Prep use.
Right.
Time for that.
I knew a student who said he didn't take any schoolwork home. He had it all like organized so that when he had classes on campus, he had days on campus that he stayed and treated it like his workplace. And I can't do that. I don't know about you guys, but that just never worked for me.
I'm not sure how he did that because it's taken up most of my time.
Right? And he was a good student. So I guess, everybody has different goals and priorities and, study needs, reading times.
How I would want it to be if we were on campus.
Yeah, we're also never not home.
Yeah,
Now, right?
we're home all day.
Yep. For those of us who had trouble bringing work home before, now we're really, that just, that whole concept went out the window, huh?
Yeah, now I just try to have homework done before like my family gets home. It's like my goal every day.
Okay, so Brett Shelton is Natalie Ruggieri. I know that now. Okay. His nickname's Natalie.
It's not just me.
Thomas Smith is not here yet. Thomas?
He's trying to get in right now.
Okay.
Yeah, thank you.
And that's it. Okay, everybody. Oh, Mariah Bales, are you here? Yeah, you're here. Gotcha. I thought I checked. What about Corey? Corey, are you here?
She's resetting her router. That's what someone said in the comments.
I think everybody else is here and it's 2 o'clock. So I'll just start with the general stuff. So I do have a situation where I've been trying to get a hold of some people all day, right? To discuss some issues. And if they call, I figured they're gonna wait till 2 o'clock and then my phone's gonna blow up, right? So if I get a call, what I'm gonna do is I'm gonna first just mute myself and see who it is, right? So I'm not like saying, go on break and then it's nothing. But if it is a call I need to take, I'll private message you guys how many minutes or whatever, and I'll stop my video also. So take a quick break and then I'll let you know when we're back, okay? I don't ever do this, but I feel like now that I said that, we won't get interrupted, right? And you'll be like, oh, what was that all about, right? Because like I said, they haven't called me all day. So let's go ahead. What I have planned today, I want to go over the crossword real quick. I want to go through our 4 exemplars. Okay, so who remembers what does RAD stand for? What's that acronym? RAD, it's RAD, right? I like the acute rads because I hate the ugly ones. I like the acute appies because I hate the ugly ones. No, everything's acute, right? Acute care. It's a good thing we're giving acute care across the lifespan, because we hate the ugly nursing care across the lifespan, right? I know, guys, I'm full of them. Just keep me going, right? Have you heard the one about the nurse? She filled out the INO every 2 hours. Under stool, 0. Stool, 0. Stool, 0. No shit. No, I'm just kidding. No, that was a bad one. Did you get it? No. Oh, okay. I know, it's been a long day. Okay, so crossword. I'm going to go over our 4 exemplars. Nobody's being brave. What does RAD stand for? Stands for asthma, but what does it stand for? You don't know? Does nobody know? Huh?
Reactive
Reactive
airway disease.
Yes, very good. Because right in that title tells you part of the patho. It tells you the disease process. So I want you to remember that, okay? That's why really the correct terminology is reactive airway disease. They've kind of changed it from asthma, right? Same kind of thing with other diseases too, you know, stroke and stuff. They want to change it to cerebral vascular accident, the CVA, because it gives you more of what is actually going on, right, instead of stroke. So, and then we have TB, which is?
Tuberculosis.
Yeah. And then we have COPD, right? So you could do like YMCA, but you can go COPD, right? COPD. I can't do the D good. Whoops. Okay. We'll have to practice that one. You gotta learn about COPD, which stands for?
Chronic obstructive pulmonary disease.
Thank you. Yes. So we're going to learn all about that and the things that lead to that. And then our last one is the PNA, right? The N is silent. So PNA is?
Pneumonia.
Pneumonia. Very good. Or yeah, the P is silent. Did I say the A is silent? The P is silent. So it really should be NA, right? We'll have all our inside jokes by the time I'm done. Because what is Brett's nickname? Natalie or what? Well, there's Corey.
I thought I changed it.
You did, but I saw it before you did. Ha ha ha.
That's my girlfriend. It's not my nickname.
Oh, that's what you want us to believe, but whatever.
She's a real person. I can vouch for that.
Oh, I see. You guys are sticking together on it. What's Tom's nickname? No. Harass the guys. Get used to it. You went into nursing. What can I tell you? No. No. Okay. And okay, so 4 exemplars. So we're going to have fun with those exemplars, okay? I'm going to set you up at the end of class in teams where you're going to go at it and you're going to compete, friendly fun, and just see who can create the best case study. So I'll talk about, you know, how we study case studies in nursing. Why is that helpful? How does it help us apply what we're learning and kind of create something we're going to see in the clinical setting? And how do we utilize nursing process and really get used to, you know, the whole thing about nursing process is, you know, I hear it all the time, and there's truth to the you know, the rationale that once you graduate, who sits and writes out care plans, right? Do you see nurses out there sitting down and writing out plans of care? Not very often, because they're clicking on icons in Epic, right? It's all computerized now. So they do, though. They have to initiate standard plans of care. They have to update them. They have to document education, and they have to resolve all those issues that the patient had on discharge. So it's kind of behind the scenes because they do it quickly at the beginning and end of shift and that kind of thing. And you'd be correct that they're not really sitting there spending a lot of time doing that because they're so darn busy, right? Giving the patient care and documenting the patient care and calling the doctors and giving the meds and doing the education and good, because good nurses should do that, right? So you want to make the documentation and all that quick and user friendly and, you know, meaningful use of the electronic health record, right? That's what it's all about, having those tools. But here's my point, okay? Nursing process is how we think. Right? We're looking, like I said, we're applying our knowledge of our concepts. Whatever we're identifying as being abnormal for the patient, we're looking at that and saying, that's an alteration in breathing pattern. That's an alteration in oxygenation. This person needs oxygen to maintain a pulse ox above 94. That's not normal. They should be fine on room air. So I know that's an alteration in oxygenation, right? So if they have an if they have croup in the upper airway swelling, right, that stridor, then we know that they have an alteration in airway clearance. Or if they have tuberculosis and they're coughing up orange tinged, bloody tinged mucus, right, then we know that they have also an alteration in airway clearance because they got these thick secretions that they're unable to bring up, you know, and they're going to have that, you know, those that change in their lung tissue from having that tuberculosis. It's a horrible disease. Okay, so, and then we move on from there. We look at the assessment findings, right? So we heard the coughing, we saw the work of breathing, we looked at the oxygen requirement. We have all these assessment findings that support those individual diagnoses. So that's our NANDA right in our head. And then from there, we go on to our interventions. What can I do independently, right? I'm going to sit that patient up high so they can expand their lungs easier. I'm going to make sure I'm repositioning them every so often. I'm going to encourage fluids so that they can cough and clear their lungs. I'm going to monitor them in their pulse ox. I'm going to look for color changes and changes in their level of consciousness, because if the brain's not getting enough oxygen, they're going to become more lethargic, right? Or they're going to have a change in their level of consciousness. And I'm going to give antibiotics and all those things that, well, I guess antibiotics is a little bit collaborative, right? Because I need a doctor's order to do that. And then after that, it's all me. So, so there's things that we can do independently. And then there's other things like calling respiratory therapy to come assess the lungs and give a PRN aerosol as needed, right? And discussing, you know, like sharing information with the respiratory therapist to determine what the severity score is for the work of breathing. Those kind of things are collaborative. Teaching the family how to use the, metered dose inhaler, collaborative diagnosis. So there's things that we do independently and there's things that we do collaboratively. And, you know, and of course, you know, notifying the doctor, SBAR. So I like to talk about, like, when I'm doing interventions, giving me 5, okay? So I know this is annoying, but just picture Ms. Erickson saying, give me 5, okay? What interventions you're gonna do independently, what interventions you're gonna do collaboratively, what education you're gonna provide to your person and family, what continued assessments you're going to do to know when your patient's getting worse or better, and based on those assessments, when would you notify the physician, okay? A lot of times when you're looking at current orders on a patient, they're gonna fall in those 5 categories for interventions. That's how I think that you would write comprehensive interventions for your patient. So someday, I know I'm gonna write my own book, right? Because I know it's genius. No, I'm just kidding. I'm in a mood this afternoon. This is good, but it's, you know, right? It could be a little scary, I'm sorry. Anyway, questions about that? Because as we're approaching exemplars, I want you thinking in terms of nursing process. Then when we get to the point where you're going to take the case study and develop the case study in the plan of care, you'll already, you know, have a lot of this in your head. And you can, do you see, and then what do nurses do? So after you implement the interventions, what do you do? So there's something we do in between that, right? You who are doing the VSIMs and doing your NANDAs, you write your diagnosis and then you sit with the patient and you say, what do I have to do? Yeah.
You develop goals for them.
Exactly. And what about those goals are important?
That they're SMART goals.
Yep. So specific, right? So that anybody who reads it is going to understand exactly what you mean. So we're not saying, I call these my bad words in nursing. Not that I've been throwing out enough bad words out there this afternoon, but within normal limits. Ooh, right? Stable. What? Adequate. Normal. What's normal? Right? Can you think of some others? Baseline for patient. Do I know what that is? Even stuff like, you know, as needed. It's like, well, how often? So you know, if you're, and then you have to think too, what's realistic, right? So specific, measurable. So making sure that if it's, the patient will know something. Well, how am I going to know if they know it? So they have to like verbalize or demonstrate or do something that I can actually evaluate it. And then, you know, is it attainable? So, you know, if they're in, you know, if they can't see, if they're blind, you're not going to get them to be able to drop their own insulin looking at the syringe, right? Something like that. So, and then realistic and time frames, right? So I think, like, especially with pain, I think a lot of times you want to set a short-term goal and you want to say, oh, by the end of the shift, right? That doesn't work with pain. Are you telling me you're going to let them be a 10 all day, and then if you give them morphine at 5 o'clock and by the end of your shift they're a 3, you've met your goal? No, right? So you do have to think about what is, you know, a patient-centered goal with this patient. You know, if you're saying they're going to walk this many times, does the patient agree that they'll get up and walk that many times, right? So just get thinking in those terms, okay? So setting the goal, and then you do your interventions, and here's where you got to stay in your lane too, okay? So if we're talking about airway clearance, you're not going to talk about oxygen, because that would go in, you know, alteration in, you know, oxygenation. So you want to stay with airway stuff, you know, positioning, assessing trachea being midline, and encouraging fluids, encouraging coughing and deep breathing, notifying the doctor if the patient starts to, you know, have trouble clearing their airway. So, okay, making sure that here's the takeaway. All the interventions need to help meet that goal. Okay, so if it's that they're going to get up and ambulate, I'm not talking about treating pain, because that would go with the pain diagnosis. Okay, I know it's so much easier when somebody else is like doing, and then you can tweak it. But it's hard when you're coming from scratch and you're looking at a patient and you're trying to go through that whole process until you've done it, right? I mean, you guys are new, so how are you going to know what you need to do for a certain diagnosis? How are you going to know what you need to do for COPD, Shelby?
Check the lung sounds and check to see how well they're breathing.
Yes, so you're going to assess to identify that that's, you know, where you're at. But then if you don't know what interventions, like that person's having trouble breathing, you're a new student, right? You're developing a case study for, you know, for class. How are you going to know what interventions to use? And actually, really, how should any nurse choose interventions? Based on what?
Well, based on how well the patient is doing.
Okay, so you're critically thinking, how well is my patient doing? But if you're really trying to pick interventions, like, okay, so the patient's not doing well, how are you going to know what to do? You know this? Have you ever seen Jerry Maguire? You know that?
Is it our evidence-based research?
Yes, evidence-based practice, right? Show me the study. Show me the study. Show me the study, Chanel. You say, show me the study, Ms. Erickson.
Show me the study, Miss Erickson.
Show me the study, Chanel. Right? Yeah. See, doesn't it, right? If I'm saying this is the best practice, right? I'm doing compressions at about 100 beats per minute, right? I'm pushing hard, I'm pushing fast, I'm allowing for full recoil. And in my head, I'm thinking, because this is best practice according to American Heart Association, baby, right? True, right? Am I truth? Okay, so how are you going to know what it is? You're going to look it up, right? You're going to go to your resources. You're going to go to Lippincott the Point. You're going to look in your textbook, right? And you're going to see what are recommended interventions for that diagnosis. You're going to go, if you're in the clinical setting, you can go to Up to Date. They have it linked to Epic. You can look it up. That's why they have those standardized care plans. And in clinical, when you're out there, you can click on Epic in the care plan, and you can go under education, and it gives you teaching points for like a new patient that's coming in. Oh, orient them to the room, orient them to pain scale, orient them to hand washing, give them the hand washing education. You know, they got it all right there. You've got resources, okay? So use your tools, okay? Okay, so I want you thinking in these terms as we're going through these exemplars. And then after we're done looking at the exemplars, we're going to take a break, and then we're going to come back and we're going to talk about maybe one of my favorite subjects, acid-base balance, because it's all about the, what, Nicole? It's all about the base.
I have no idea.
Who said it?
The base.
Right? So sing it. You guys are shy? It's all about the base and acid. It's all about the base and acid. It's all about the base and acid, right? We're learning compensation facts and we're bringing balance back. Okay? Again, we'll learn the lyrics, right? First, we'll learn the basics, and then we'll learn what systems compensate if you're acidotic or you're alkalotic. That's where we're going today, okay? And then I'll break you out into your teams, and the competition will begin. Okay? Questions about where we're at, where we're going? We're all awake now, right? You guys are ready for this? Are you? Are you? Okay.
Most definitely not.
Thank you for being honest. Uh-oh. Okay. Everybody can see my screen? Let's see, I got chats. Do I even want to look? Oh, you know what we forgot? Did everybody turned in this crossword puzzle? Okay, everybody off mute for a sec. So I want to do this real quick. I'm gonna be calling on you. Everybody got this?
Oh, whoa.
Stick it in. Okay. Number 1 across 3. I guess we start with 3 across, right? Sydney Bramlett, Penrod.
Diaphragm?
Yep, diaphragm, good. Kaylee Engel. Kaylee Engel?
Yes.
What'd you get for 4 across?
4, I got ventilation.
Right, but do you think that's the correct answer, really?
No.
It should be.
Respiration.
Exactly, yeah. I didn't do the crossword. They got it wrong. Okay, good job.
What was it?
It should be respiration instead of ventilation. Yep, somebody emailed me about that and they were right. And Corey, how do I say it? Herjon?
Errejon. It's okay. It's Errejon, but most people
can't
can't
feel the
roll the
R.
R's. Yeah.
Herajon. You're gonna have to help me practice that one. Okay, 7 across.
Let me open this. I have to Kipnew.
Yep, that's too fast. 10 across. Brittany Kiros.
Respiration, but it should be ventilation.
Exactly. Okay, 12 across. Melinda.
pH.
Yep. We're gonna learn what that means. Do you know what the pH means? What's that stand for?
It's the power of hydrogen.
Yes. How'd you know that? You're so smart. How'd you know that?
Anatnphys.
From what?
With Miss Coes in
All right, I'm
Anatnphys.
gonna have to tell her. Way to go. Okay, 14 across.
3:30.
Who said that? I heard that. Allison Johnson.
Ventilation, perfusion.
Yes. All in one word, huh? That's a new compound word. 15 across. Let's go with, let's see. Tawny.
Apnea.
Yes. 20 across. Esme.
Buffers.
Buffers. Very good. 23 across. Xena, Warrior Princess.
Oximetry.
Yes. Do you get that all the time, Zena?
Yeah, ever since I was in elementary school.
Yeah. Have you ever dressed up like Xena Warrior Princess?
No, I've always wanted to.
We in boot camp, we do our Xena Warrior Princess exercises. So I'm sorry, I can't help it. It's a great exercise workout. Actually, it's really some good exercises that we put together and named after you. And now I finally meet you. Okay, so did you answer 20? We were on 24 across, right?
Yeah, I said pulse oximetry.
Okay, that's, yes, okay, thank you. 23 across, very good. Okay, Alicia, 24 across.
Acidosis.
Yep. And 27 across. Madison, Somerville. What'd you say?
Alkalosis?
Yep, exactly. Very good. 28 across. Apsara.
Cyanosis.
Yep. And 29 across. Sarah or Chanel Klein.
Acids.
Acids. Yep. Okay, we're going down, right? One down and two to go. Mariah Bales.
More singing.
Brady Pena.
Good job. What were you saying, Tom? You got number 2 down?
Wheezing.
Thank you. 5 down. Let's see, who haven't I? Isla Guerrero.
Oxygenation.
Good job. Alexandria, 6 down.
Hypoxemia.
Yep. 8 down, Monique. Monique Mendoza.
Bronchite.
Thank you. 9 down, Robert Kershaw.
Hypocapnia.
What'd you say?
Hypocapnia.
Exactly. Yes. Good job. 11 down, Vivian.
Pneumothorax.
Good. Yep. So we want to remember the difference between a pleural effusion, right, where fluid is built up in the lungs, pneumothorax, where there's air entering through the diaphragm into the lungs, right, or hemothorax. Did I give away other answers? No. Good. Okay. So, because that's always bad when you're going on, right, and you gave away all the answers. Okay. So pneumothorax is a partial lung collapse resulting from air or gas collecting in the lungs or in the pleural space that surrounds the lungs, right? And then you can always just stick in a needle, right? And you hear the whoosh of the water or the air come out, and then the lung expands. Okay, okay, number 13 down, Rachel.
Arterial blood gas.
Good job, all one word again, right? 16 down, Morgan. Organ stump. Like, Morgan, are you here? I don't see you in the lobby or anything. Okay. I don't know. Maybe something happened with their internet, huh? Keep an eye out for her, guys, okay? Because you know how I don't pay attention to that. Okay. Let's go with Stacy. Number 16 down, please.
Atelectasis.
Atelectasis.
Atelectasis. All right.
Yes. Remember, if you ever do, like, if you're going to do a presentation and you're like, oh no, I have no idea how to say that word. In the point, there's the Stegman's Medical Dictionary, and it has a nice little volume thing on it, right? One of those little speaker things. You can click on it, and the voice of God comes in and says, atelectasis.
Miss Erickson, are those switched as well? The pneumothorax and are those switched as well? The pneumothorax and the atelectasis? Because isn't a pneumothorax a full collapse and the other one's a half or partial?
The collapse of lung tissue is atelectasis. No, I think that's correct. It's in your book, so you can look it up. And actually, we're going through it today, so I'll read exactly what it is. Let's read
it says
exactly.
Pneumothorax is a complete collapse, and the I can't say the word, telexisis is a partial collapse.
Right.
So they're switched on the crossword as well.
Affecting all or part of a lung. I'll look at it. Okay. Thank you. Okay. 17. Tamara?
Dissolved gas.
What'd you say, dissolved gas?
Yes.
What's another word for that? For something that is not stable? You could also say volatile. Or it could be volatile acid too. But you know what? I'd take dissolved gas because you're right that it dissolves and then it goes into different compounds and can be excreted. Yeah. Okay, number 18. Did I call on Alexandria yet?
Yeah, but I can answer it.
Thank you.
It's orthopenia.
Yes. Do you remember? So if they have difficulty supine, right, or being flat, then what might we ask them to evaluate how serious their orthopnea is?
I'm not sure what that is.
Back in the day, we used to say, is it one pillow or two, one pillow orthopnea, two pillow orthopnea, three pillow orthopnea, four. If they got four, they're out the door. No, I'm just kidding. We don't have that many pillows in the hospital. You run around, you can't find the pillows. They're all in the guy's room that has a 4-pillow orthopnea. So, okay. 19 down. Nathan.
Hypercapnia.
Yes. 21. Ooh. Let's see. Brett.
21, I had stridor.
Yes, make the sound. What's it sound like?
I don't think I can right now.
Ooh, there it is. Ooh, there it is, right?
Whoop,
Okay.
there it is. Whoop, there it
See,
is.
you guys are going to have this in your head all day. You're going to be I have had students after they've graduated, after boards, come and tell me, I'm sitting in there and all of a sudden I see something and I start laughing because they're in there singing the song, right? So whatever works, I say. So you got to be careful though, because sometimes I say it in a patient room, right? And the other day, this guy, we were doing a Foley catheter on this older man. And he said, I hope she doesn't hurt me because the last 2 people who placed the catheter hurt me. And I said, no, we won't, because I teach the students it's all about the lube. And he just kind of looked at me and I said, but it is, and I said, yeah, make sure you're lubing up that catheter really good all the way. And you know what he said? It didn't hurt. So there you go, right? But like I said, you never know when, you got to make sure you develop that rapport first. But, at one of the pinning ceremonies, the students actually had a picture of me and had like the quotation on there, it's all about the lube, right? And I thought, oh boy, what are people going to think, So, yeah. So I'm glad you guys are getting to know me now a little bit. So it's not the same as in person, is it? Okay, so we're almost done. 22 down. Trevor.
Crackles.
Thank you. 25 down. Shelby.
Dyspnea.
Perfect. Who hasn't answered yet?
I haven't.
Who's that?
26 down is acids.
Yes. Well, accepts. So if they're accepting hydrogen ions in solutions, hydrogen ions are the acid, right? So what would accept them in solution?
It's the base.
Bases.
But, yeah.
So the bases accept the acids. But I see why you would say, because the hydrogen ion is, the hydrogen is the acid, right? We're going to talk about that more, but good. Okay, thank you so much for playing along with that with me. Good job. I hope it got you familiar with the different terms and questioning some of those, right? Okay, so let's go really quick. I want to go down to where we were here after the break. Okay, so asthma, and I like to say it's rad, right? Asthma's rad. What is asthma? So what is reactive airway disease, right? If somebody's like, I just, okay, so we used to do play therapy with, well, they still do play therapy with kids. So you could take a shirt that says asthma and you could put it on yourself and say to the kid, oh no, I just got asthma. What is it? What did the doctor tell you? What is asthma? What would you tell a kid like that, Tamara?
That it's like your airway swells and it kind of gets, so it's hard for you to breathe because it's like swell and like.
Perfect. Yes, that's one of the first things in the disease process, right? You have inflammation of the airway. And especially in kids, right? If your airway's already smaller and now you've got this inflammation of the tissue of the airway, their airway closes up even quicker, and it's even more narrow and small. So, that's why we see, like, some people say, oh, I had asthma so bad when I was a kid, but I outgrew it. I mean, there's some truth in that, right? Because their airways got bigger. But it doesn't mean that they still don't have that reactive airway. If the perfect storm happened and they got a virus and they got, exposed to things that are triggering their asthma, and then they're stressed or whatever, right? And then all of a sudden, oh, I had an exacerbation of asthma. I haven't been sick with it since I was a kid. Well, yeah, you outgrew it, but it doesn't mean that you ever get rid of that reactive airway disease. So yeah, good job. And I like the way you said that the airways get swollen, everything, so, and then medically we'll say, the airway inflammation, because it triggers that. What is that inflammatory response from? Histamines, leukotrienes, right? Things in our system that trigger that inflammatory response of the cells. It mediates, right? Mediates and causes inflammation. And it also, along with the inflammation, what else does it mediate? What else happens? So think of what you know about asthma and the symptoms. So what do people do? They wheeze because of the airway swelling, right? So airway inflammation and narrowing of the airways causes wheezing. What else causes that wheezing?
Extra mucus production?
Yes, exactly. The airways are getting blocked, right? So we have an alteration in airway clearance because we have inflammation that narrows the airway, and we have mucus that's blocking the airway, because that reaction mediates that response. Our body, normally our secretions help clean out, right? We got that CLI kind of brushing out that fluid that kind of helps, lubricate and keep our lungs, moist, and we need some of that, some of that in our pulmonary system. But too much of a good thing, and then we're all congested and we're blowing our nose, like, where's it all coming from? Where's all that snot come from? It comes from your inflammatory reaction in your body, producing that to try to get rid of whatever is triggering it, right? If it's something our body's reacting to, or if it's a virus that our body's trying to get rid of, it's not funny, right? Anyway, so yeah, increased mucus production because it's not funny. Come on, guys, I'm losing you. Okay, tough crowd. Okay, so, and then increased airway swelling, and what's the last thing? So, and it all causes wheezing. What's the other thing that causes wheezing? How does the person feel?
Shortness of breath.
Why?
Because they're not getting enough like air, because their airways are like very narrow and swollen that they can really.
What else is tightening those airways down? What happens? Why does albuterol work? What does albuterol do?
Is it bronchospasms that cause the airway narrowing?
Yes, the beta cells, right? So you have tightening, the bronchospasm, the tightening of the muscles. So we have muscles around our airways, right? That help keep our airways open, help us breathe. But when you react to a trigger, those muscles tighten, right? So you got tightening of the muscles around the airway, inflammation of the airway tissue. How do we treat inflammation of the airway tissue? What do we give people?
Albuterol.
Albuterol is for the muscles. The albuterol is the beta adrenergic, right? Beta adrenergic inhaler that helps relax the muscles. What's that?
Is it antihistamines?
Antihistamine would help the histamine response, yes. Anti-leukotrienes is your singular. That helps with leukotriene production, so response to leukotrienes. So yeah, you can have, but the only thing is like your antihistamine, you don't want to give Benadryl because for a lot of people, Benadryl is going to drive their secretions and make them more thick and stuff. So, you know, so there's not a lot of that, but there is the singular for that leukotriene for people who react to that. But what else do we give for inflammation specifically? What is our anti-inflammatory? What's that?
Steroids, corticosteroids?
Ding, 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 yes, right? And we can do, and you know what parents are always saying? Oh, I don't want to give my kids steroids, right? Because we know how bad steroids can be. Steroids can cause aggressiveness, it can immunosuppress. So then what do you do if a kid has a virus, but then they have an asthma attack, you know, if you give, right? So, and then, you know, steroids can be bad for bones and muscle and all kinds of stuff, right? Bad steroids. Okay, but if they do an inhaled steroid like Pulmicort, Asthmanex, some of those, you know, inhaled steroids go locally to the lungs, they don't absorb systemically, and they don't cause as many of those symptoms. So in doing a preventative inhaled steroid every day as ordered helps prevent the child from having a reaction to the trigger in the first place and improves lung function over time. Did I just sell it? So if you're improving lung function over time and preventing exacerbations, then you're preventing the child from needing bursts of oral or IV steroids that then do need to be weaned off. Why, when we give steroids, why do we need to wean steroids? That's a tough one. I'd be surprised if you guys get it. It's a challenge question of the day. Because hormonally, we got to keep our balance, right? Because it affects the adrenal glands, and you're going to learn about that. This isn't in our class even. Adrenal insufficiency, right? So if you're giving steroids, then the adrenal gland's not going to produce as much corticosteroids, and then if you cut it off real quick, then you're going to not have enough cortisol in the system. Your body needs cortisol. It's a stress hormone, right? So you don't want to all of a sudden take that away from the body and have adrenal insufficiency. So you slowly, you taper it. If they've been on a steroid burst more than 24 hours, something like that, you know, usually they'll do like a week taper. Okay, so just file that one away, and then you can impress your friends and neighbors when you know it. Okay, so asthma is this chronic inflammatory disease of the lungs, which narrows the airways, right? Typically caused by an external trigger, all kinds. We'll look at all the different triggers that can cause reactive airway disease, and can lead to, what I gotta move your guys, you're in my way. Okay, so a chronic inflammatory disease of the lungs where narrowing of the airways occurs, typically caused by an external trigger, allergen, pollen, stress, can lead to permanent structural changes of the lungs. What are some common signs and symptoms? You guys, you got it. Good job, Tamara, right? Narrowing of the airways, tightening of the muscles. They'll say, what do people say? I feel tight, okay? My lungs feel tight. And then the increased mucus production. So for the tight muscles, we give albuterol. For the inflammation, we give steroids, either inhaled preventative and steroids or IV or PO, usually like methylprednisone. And then for the increased secretions, we may suction if necessary for the little kids that can't blow their nose and cough it out, or we increase fluids, right? But we're not going to do cough suppressants. Only in the person that's like been cough, 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 and they haven't gotten any sleep or right? Because they need to cough and clear that stuff. So we push fluids. If they're dehydrated, we give IV fluids. And we make sure they're well hydrated to thin the secretions and help them cough and clear, okay? So wheezing, coughing. Why would they be apprehensive?
Because they're not getting enough air in.
Exactly, sign of hypoxia. If they got that scared look on their face, they're trying to tell you something. Yeah. Is asthma life-threatening?
Yes.
Good, Melinda. Yes. One of the things that I would like to remind parents is if they're at home with their child and their child's having distress, and if they're doing treatments, they're scared, just call 911. It's okay. If the child's better and the paramedics get there, they're going to be happy. And I've asked paramedics this and they said, yes, that's fine, right? So because I've had, I've heard, I've seen where people put their child in the car and they're driving to the hospital and they get stuck in a wash or something happened, right? And then they're stuck and then their child's turning blue. And then it's very, and then they're lucky that the child didn't go into respiratory failure in the car, right? So it's like, if you're getting that feeling that you're feeling a little scared, your child's scared, just call the paramedics, just because it can be like, kids do die of asthma, adults, people die of asthma. So yes. Yeah. I mean, it's also very treatable and it's a lot of fun because you can really turn people around quickly. There's a lot of teaching that goes into asthma education. It's actually one of our core measures to provide 100% of patients, whether they're coming in with an initial diagnosis of asthma or they have a secondary, people who even have a secondary diagnosis of reactive airway disease, we make sure that they don't have any questions or want updates on asthma education when they're in the hospital. And we provide it and we document it. So yeah, there's a risk of that airway closing off. There's a risk of respiratory failure. Goal of the treatment. What's goal of treatment? Somebody give me a SMART goal. Give me a criteria, right? Talk about SMART goals. The simpler, the better. Yeah, Madison.
Reduce swelling in the throat.
How will we know that?
How do we know that?
Yep. Am I going to look in the throat? So make sure it's specific. How am I going to evaluate that?
Noises that they're making and how their breathing is going to come out.
Okay, so how would you state that? Clear breath sounds by the end of the shift. Patient respirations easy with no retracting, nasal flaring, or respiratory rate lower than respiratory rate between 16 and 20.
Yeah, sounds good.
By the end of the shift or throughout the shift. Patent airway throughout the shift. Are those all? You could look at the patient and say, yes, their airway's patent. And sometimes that's all we want, right? We leave for the end of the day and we're like, woof, they're all breathing. Okay, so we got that down, right? Any questions about that? Making sure that it's measurable, attainable, realistic, and that we got that time frame in there. You're all going to be perfect at writing goals. Just remember, like, what is a good trick? When you're doing your care plans, so do your care plan, and because I know we talk about concept maps and all this other stuff, right? But I want you to also think of it being the plan of care that somebody else, like if I don't know the patient and you know the patient, you're handing this to me and I'm like, okay, I got it, I know what to do, right? So you write your care plan and you put it away and you come back and read it as if you haven't seen it before and you don't know the patient. You're like, I could look at this and know exactly what I should be doing and how I'm going to evaluate if it's working. Okay, have you had it kind of explained to you like that before? I think it's helpful to know how, why, right? How, why, what. So yeah, so goal of the treatment, reduce airway inflammation with medication, so maintaining a patent airway, right? So I like these cartoons. They're another thing that kind of sticks in your mind. You look at this person, their face looks anxious, right? They're retracting. You can see those ribs. They're tachypnic. They're, tachycardic. He's got his albuterol in one hand and maybe his oral steroids in the other. So we think about triggers. You know, they have that hypersensitive immune system that's reacting to these things. It could be an upper respiratory infection. A lot of times viruses, you know, some person will just get a cold, but the person with asthma ends up coughing and coughing and coughing for weeks. And then exercise, of course, we have exercise-induced asthma, especially if they're on grass and they're also allergic to grass. Weather changes, wind, rain. We used to know, you know, I think there's a lot of inflammatory types, diseases that are related to inflammation, right? Familial tendency, it is a, you know, there are genetic factors that put people more at risk for asthma. You know, so people can react to perfumes, to cockroach dander, to other pet dander, to emotions, you know, like if they're really stressed, crying and stuff, and then they start to have, you know, bronchospasm with their airway. Things like hairsprays and cigarette smoke can be a huge irritant to the lungs and can really trigger asthma. So dust, pollens, food dyes. Think of anything else? I think I got more in here somewhere. So the idea, what I like is when the person comes in and they're having their first, you know, symptoms of asthma and everything, you say to them, you know, what have you identified as your triggers, right? So if the stuffed toys are around and, you know, they're dusty, or molds, you know, like going, you know, somewhere and there was a shower with mold in it or something, some old stinky hotel with bad carpet, right? You know, and then they have the reactive airway disease, or they went to somebody's house that was smoking or that kind of thing. So you got to identify those triggers and try to avoid them. That's the best way, is just to avoid the triggers. And of course, trying not to get sick, right? Good hand washing is really important. Exercise then so you are healthy and not, and then if the child does, or the adult needs their inhaler before exercise, you know, not letting the exercise induce the asthma. Males, there's a little bit more occurrence in males, onset before 12 years of age. There's things that put people at risk for asthma, having RSV within the first year of life, prematurity, you know, other lung disorders, of course, would put somebody at risk for developing reactive airway disease. So, you know, and then the hypoxemia is, you know, the consequence of the asthma, that, you know, they need oxygen. They're not moving air well enough, so they're not, you know, when we think about that VQ mismatch, remember, you got to have that ventilation, right? So if the airways are tight and they have increased mucus production and, you know, there's inflammation, there's not going to be that good expansion of the alveoli, and there's not going to be that good ventilation to allow for the perfusion. So this is more of a ventilatory disease than a perfusion kind of disease, right? So then the restlessness comes from the hypoxemia and the increased work of breathing. Cough, mucus, shortness of breath, expiratory wheeze, because it's usually the lower airways that are kind of collapsed, and so you get that expiratory wheezing. So hang on to this one, because the CO2, that's carbon dioxide, right? I like to call it carbon diacid. So we remember that if you have increased CO2, you have increased acid retention. You're not getting, your lungs are not able to get rid of that acid as much. So you're going to get respiratory acidosis with asthma, okay? That's coming in part 2. Prolonged expiration, because they're going to have some air trapping because of the increased inflammation. And they're going to retract because they're working to get that air into their lungs. They could have tracheal retracting, substernal retracting, intercostal retracting in the ribs like his. Okay, they can have use of accessory muscles where they're using those muscles to breathe. If they start to head bob, you know they're getting tired out and they're probably going to start going into respiratory failure. Okay, so if they're doing, I went and did a summer camp stint. I used, you know, for my kids' school, middle school, out in Pine Canyon Methodist camp up in the Chiricahuas. Gorgeous, fun. Camp nurse, right? One child had pretty severe reactive airway disease, didn't realize how severe. Then I also had a patient that had diabetes that was on a pump, okay? Her glucometer was in a case, but you know how kids are, they jumped on it and they actually broke it in the case. So she didn't have her glucometer now all of a sudden out in the middle of nowhere. And then they were doing this game in the mess hall where they were carrying kids on their back, piggyback, and they were sliding on cardboard, on cement, dirty, you know, sandy cement mess hall, and they created a bunch of dust. And this girl, Sabina, came to me and she's looking kind of dusky and she's like, Ms. Erickson, I'm having trouble breathing, right? So I bring her into the nurses' quarters and, you know, hooked up a nebulizer and she's sitting there doing her treatment. While she's doing her treatment, they started the big campfire down in the, you know, in the area to start the sing-along. And the smoke from the campfire kind of came right up into the tent, and we had all this smoke all in the whole camp area, and she was really starting to have trouble. And I was like going, okay, so what do you do at home if your treatments aren't working, you know, right? So I just kind of sat her there, got her to relax, and started to think about the PICU number and who would be the intensivist on call and how they could probably send a helicopter to the, you know, the softball field for me, you know. Because at that moment, then the girl who had the broken glucometer came in and said, you know, I don't know what to do. You know, she had been running low all day on her blood sugar. So we kind of turned her pump down and came up with a plan to get, and she didn't have her backup glucometer. That was a fun, that was a fun volunteer. I didn't sleep that night, by the way. Woke the girl with the diabetes up every hour, making sure she was alert and everything until they brought the glucometer and we tested her. She was good. And the girl, you know, got her treatment, started breathing, kept her with me just to make sure she was okay. So fun times. But, and that same girl, we were marching in a parade with the school. She got behind the Shriners cars, the little cars, and had another reactive airway disease attack. She actually had another one at school, now that I think about it. And I thought they said dog attack. So I was like, who got attacked by a dog? And I went running, and it was her again, having trouble breathing. And she was blue, and the paramedic said, her pulse ox isn't picking up because of her fingernail polish. And I was looking at her, I'm like going, no, that's real. She looked at the patient, not at the pulse ox. You know, I was like, I think she needs some O's, you know. So fun times. Because, you know, you're always the nurse, right? Okay, questions about asthma. Was that enough? You got it all? Oops, you guys froze for a sec. I hope I didn't lose my internet. You there? Oh. Uh-oh, I might have lost you. Sorry about that, I'm back. Can you hear me okay? Okay, maybe that's a sign that we should take a break. Let's take a break and come back at 3:05, okay? Hi, Morgan. You made it just in time for lost internet twice.
I just lost
Okay, welcome back, everyone. So what is COPD? You already told me that it's chronic obstructive pulmonary disease, right? So there's two disease processes that contribute to the development of COPD, to this chronic obstructive pulmonary disease. So one thing about something being chronic, did you learn in HSC 125 that chronic means that sometimes they'll say like 6 months, right? But with chronic bronchitis, it's 3 months of, you know, chronically coughing up sputum and having that kind of disease process of the bronchioles being inflamed and having secretions. So, you know, the thing with chronic disease is you have periods where they're kind of, you know, they're in recession, you know, right there. And then you have these periods of exacerbation. So the thing with COPD is helping the person learn how to manage their disease process at home and how to prevent exacerbations. So what causes exacerbations for them? Is it, you know, getting viral illnesses, getting the, you know, problems with the bronchitis? Is it that they overdo it and they, you know, get themselves too tired out and short of breath, and then they struggle to breathe? And then emphysema is more of so there's the two processes, but the emphysema is kind of more end stage, where the alveoli, and there's some great pictures in your book of this, where you get this obstruction with the secretions and everything that cause the alveoli to actually overstretch, and then they lose their elasticity, right? So if they can't expand and contract and they're overinflated, and then they're not able to expand and get oxygen in them, they're like, you know, balloons that are leaking out kind of thing. So you don't have that gas exchange. So COPD is this combination of chronic bronchitis and emphysema. Sometimes there's a little reactive airway disease component also, but don't let that confuse you. If there's a test question about it, it's going to be that bronchitis and emphysema that results in the decreased ability to protect the airway and maintain proper gas exchange. So chronic bronchitis is that damage to the cilia, those little fine hairs, kind of the sweepers of the lungs, along with increased mucus production, paired with this chronic cough. It's lasted more than 3 months, and they get diagnosed with chronic bronchitis. Upper airway defense is decreased. So, you know, think about this. Every time you get a lung infection, right? I know as nurses, a lot of times every year, you know, RSV, and I think, you know, is this setting me up for COPD someday, right? Number one, don't smoke, right? Two big lessons in life. Don't smoke, don't do drugs, right? That's like big, it's huge, right? For your health. So yeah, don't smoke. Exercise, you know, don't keep getting sick year after year after year with pneumonias and bronchitises and that kind of thing. So, and what's emphysema? It's that damaged alveoli that then remain stretched out, and they lose their ability to deflate during exhalation, and it leads to air trapping also, right? They inhale, they can't really exhale. It's lost that that's easy for me to say, blah. Okay, why are either of these a problem? Ventilation, perfusion mismatch, more of a ventilation problem, right? So COPD, chronic airflow limitations, emphysema and chronic bronchitis. Here's your guy, right? Notice how he's positioned. And he's got his cigarette with his O2 tank. Bad. So he's easily fatigued, frequent respiratory infections, use of the accessory muscles to breathe, a lot of work to breathe. Orthopnea, he's sleeping with those pillows at night. He needs to be kind of upright at night. Cor pulmonale is a fancy name for right-sided heart failure, okay? When you have increased pressures in the lungs, you have pulmonary hypertension, it puts work on the right side of the heart. Remember? It's to the left, it's to the left, to the left, to the left, to the left, to the right, right? No. To the right, to the right, to the right, to the right, to the left, to the left, to the left, to the left. Now pump, now pump, now pump, right? And circulate it out and return back to the heart, right? So it goes from the right atrium to the right ventricle to the lungs, to the left atrium to the left ventricle, out through the aorta to the body, right? So if there's high pressures in the lungs, it's going to put a lot of pressure on that right ventricle, and then you're going to have right-sided heart failure, cor pulmonale. Thin in appearance, wheezing, pursed lip breathing. That's a big, but it's also a technique that we can help for them to help them get that air out, to exhale, and to help with their work of breathing. It's like blow out the candles and breathe in. Oh, and smell the flowers. Smell the flowers, blow out the candles. Smell those flowers, blow out your candles, right? So we'll all relax, practice that, right? And then you can do your Kegels after that, right? You know what Kegels are too? Where you're tightening your pelvic floor muscles, you know, all these good little tips in nursing, you know. Okay, chronic cough, barrel chest, because of the work, you know, they're trying to get that lung expansion in their body. You have these changes in the actual body structure. Shortness of breath, pain on breathing, dyspnea, prolonged expiration time as they're trying to get out that trapped air, digital clubbing, because they're going to have poor oxygenation to their extremities. Our mannequin in the sim theater in the lab, Ms. Morelli, when she gets the skin off and she's trying to put the new skin, that rubber on that, you know, that mannequin arm, can't get those fingertips quite right. Perfect, because it's a great example of clubbing. So you can go in there and you can kind of see those flat fingernails and those kind of clubbed fingers, and that's what it looks like. So we always talk about kind of the pink puffer, and that's more your emphysema patient and how they're going to present. And then your chronic bronchitis. So depending on if they're more one or the other, you'll kind of see these features in your patient. So you can kind of tell what was more the cause. Okay. So your emphysema person, the pink puffer, they're really working hard to breathe. They're thin because of all the energy. They have decreased CO2 retention. They're not going to be acidotic because they still have all that work of breathing and they're able to get the CO2 out. Minimal cyanosis, pursed lip breathers, dyspnea, minimal cough, hyperresonance on chest percussion with air in their lungs, orthopneic, barrel chest, exertional dyspnea, prolonged expiratory time, speak in short, jerky sentences because they're still really working to breathe, and they're anxious because they're working to breathe, use of accessory muscles, and thin appearance because of all the energy that they're putting into breathing. Where your chronic bronchitis person that's kind of had this, you know, inflammation of the lungs, and they're your blue bloater type of patient, dusky and cyanotic, recurrent cough, and an increased sputus production, both are going to be kind of hypoxic and have oxygen requirements. This guy's going to retain CO2. He's going to have respiratory acidosis. That's going to stimulate more red blood cell production. So his hemoglobin is going to be increased respiratory rate, increased exertional dyspnea. A lot of chronic bronchitis also have the increased incidence in heavy cigarette smokers and digital clubbing of the fingers, cardiac enlargement, the cor pulmonale, use of accessory muscles to breathe. So that will lead to right-sided heart failure, or the cor pulmonale. So these are posted in Blackboard. You can go back in there, print up your cartoons, put them up in your, so that's gonna be your homework too. Putting up your cartoons and reading these every day, and printing up that acid-base article that I posted in there, my very favorite article on acid-base imbalance, and reading that about the 3 defenses of the body, and just reading that every night for the rest of your life so you never forget it. It'll be like your bedtime story. You're welcome. Tuberculosis, TB, infectious disease, primarily affects the lung, parenchyma may also disseminate. So you can get meningitis, tuberculosis meningitis, right? You can get it in your bones. Dogs get it in their bones too. And so it's an acid-fast rod that grows slowly, sensitive to light and heat, likes those dark places. So yeah, signs and symptoms of TB, low-grade fever, night sweats, that's a big thing, right? So not just menopause, not just other problem, HIV with night sweats, right? TB, big symptom. Weight loss, fatigue, cough, may have bloody sputum that they cough up. Extrapulmonary disease is more prevalent in HIV positive patients because of their poor immune system. Then they are more susceptible to getting TB out there. It is very life-threatening. It's so interesting, your book, that something like 1/3 of the world's population, we don't realize it because we're in the United States, right? But a lot of these third world countries and other, you know, TB, third of the world's population has tuberculosis. Isn't that huge? I think that's what I read. Something outrageous like that. Millions, billions, right? Major worldwide health problem. Morbidity and mortality rates continue to rise. Oh yeah, there it is. I was right. An estimated 1/3 of the world's population will be infected, and TB continues to be a leading cause of death. Boom. What's the goal for treatment? Don't get TB and treat it with a multi-course of antibiotics, right? So it doesn't become drug resistant and get more difficult to treat, and cure it, right? Get it to go into remission, and don't keep spreading it all over the place. So we want to get skin tests to make sure that we're screening for it so that people don't have it dormant and could actually infect other people, right? And make sure your patient's oxygenating well and doesn't die from it. So what do you think? Airway clearance, effective? Coughing up secretions, education, knowledge about why it's so important to take all your antibiotics and not partially treat this? Other goals? What would be some other good goals? Patient will be pink and alert, and pulse ox will be 95% on room air. All shift. Okay. Measurable, obtainable, realistic. We'll maintain isolation precautions. So your patient's not going to come walking out of the room and cough all over everybody, because you're educating them, and you're going in there with either your, because this is an airborne one, right? TB is one of the airborne isolation organisms. So you got to wear either your N95 mask or you got to go in there with the hood. Have you seen the Max Air hood? See, I like living in the hood, because because then you can play the robot. If you haven't seen a Max Air hood, when I'm done, you can go Google it, and then you can imagine doing the robot in the hood. Okay, so this guy, right? Another cartoon for you to print. Progressive fatigue, malaise, so kind of nauseated, not eating real well, anorexic, weight loss, gross secretions. They're kind of like orangey, yucky. Night sweats, hemoptysis, pleuritic chest pain, low-grade temp, and you can see these fever curves too. The temp will go up in the afternoon. So they need medications for 6 to 12 months to completely treat it. After 1 to 2 weeks, they're not considered contagious anymore if they're compliant, if they're adherent to the whole taking all of the meds. And that's the problem, is a lot of times they're on INH and one of the like rifampin types of, these different types of spectrum antibiotics, so that they have, they're not just taking one med. How many of you take like three? Some of these people have to be on 5 different meds if it's multi-drug resistant. And the problem is they have to keep refilling them, right? Because they're going to be on it for a while. So if they're moving around, or if their insurance changes, or they feel like they're not tolerating them well and they can't take them, then they're not going to, be compliant, and they could get drug resistant TB, or it's not completely treated and they're still contagious. So if they're acutely ill, they're on airborne isolation in the hospital until negative sputum. You can get chest X-rays, and you can see it's horrible how this mucus tends to really damage the lining of the lungs and cause these calcifications, and really affects the oxygenation status in that way. So looking at those nodules and things on the chest X-rays. Okay, what's pneumonia? Inflammation of the lung lining caused by various microorganisms. You can have your community-acquired pneumonia, including bacteria, mycobacteria, fungi, the fungus among us, right? The fungi are not so fun, and viruses. So you got your, human metapneumovirus, your adenovirus. I say adeno, you say adeno. Your influenzas, all those things can cause pneumonia. The mycoplasma pneumonia, we like them to get their pneumonia vaccine, right? Especially people in long-term care settings and prisons and other, community type of, where there's a lot of exposure to people and they can start spreading stuff around, right? So it affects both ventilation and diffusion, and because they can't exhale either. And inflammation, you have increased white blood cells, especially, the bacterial pneumonias, and bronchospasm. Because of the hypoventilation, ventilation perfusion mismatch occurs in the area of the affected lung. Usually it's one lung or the other, but it could be bilateral pneumonia. So it's really helpful if we can get that sputum culture, right? That first thing in the morning, if they're really coughing up secretions, we can send that for a culture and we can get antibiotics. If that infection has spread into their, into their blood system, and now they got septicemia because it's in their blood, we could get blood cultures and we could identify the organism that way too. So it's really important to get this workup and get these labs before starting antibiotics. Because if they're partially treated, then the chances of you actually getting an accurate culture and knowing what you're treating is going to be, less. So you can have bronchial pneumonia where it's kind of more diffuse in the bronchioles of the lung, or then that lobular. And actually, sometimes this gets so consolidated, they may need a chest tube to drain it, or they could even remove, if sometimes then this causes such a damage to the lung, it becomes necrotic and they have to remove part of the lobe if it's not going to recover. So, they get into like lung abscesses and that kind of thing in your book too. When you're doing your reading in these chapters, I kind of want to give you a little break, okay? Focus on the exemplars. We're not, I'm not going to, while the other stuff, like if you like to read the whole chapter, go for it, right? Because sooner or later you're going to get there. In more advanced, you'll come back to it. So if you want to read about, like lung cancer and that kind of thing, fine. But I'm not testing you on that, okay? I'm expecting you to learn these exemplars and apply what we're talking about today to showing me understanding of it in developing the case study assignment. Okay, so focus on these 4. And like I said, if you're really into the other, if you like just having the whole picture of that whole chapter, then that good. Okay, so looking at the symptoms of the patient, especially when they have fever. Fever causes you to be tachypnic too. So when that fever spikes a lot of times in the afternoon, your patient will start looking really crummy. Take their temperature, give them some ibuprofen or Tylenol. There's controversy about that. Low grade temp, great, will help fight the infection. But if the patient's really uncomfortable and it's affecting their pulmonary system and their circulatory system where they're, tachycardic and really uncomfortable and, their color's not looking as good, then getting that temperature down a little bit to make them more comfortable and able to breathe is good. So how does that affect acid-base balance? Okay, so hydrogen is always being produced by our body as a byproduct of metabolism. Hydrogen is a positive cation, right? So that is the measure of the acidity. So you got one hydrogen molecule, 20 bicarbonate base molecules to maintain balance in our bodies. Isn't it amazing? Usually our bodies are right at, what's a normal pH? Right on the money for us, 7.4. 7.4, we're not going to be really far off that. Nor, we say the normal range is 7.35 to 7.45, but it's really not going to be, so if you just think, 7.4. So measured as the hydrogen, the power of hydrogen, an increase in hydrogen, so it's opposite, okay? With increased acid, pH goes down. So acidic, the most acidic you could have is like a 1 or something, right? The most basic you can have is 14. So, 7.4 is pretty much right in the middle. And so the lower it is, the more acidic you are, okay? The higher your pH is, the more basic you are, right? The more alkalotic you are. So normal pH that we can live with is 7.35 to 7.45. Below 7.35, we're acidotic. Above 7.45, we're alkalotic. Okay? Some of our body's naturally occurring acids include lactic acid, right? We work our bodies, we exercise, we have a buildup of lactic acid in our muscles. Ammonia is a byproduct. in our kidneys, and then hydrochloric acid in our stomach to help us break down and digest food. And then we have our buffers. So how do buffers help with acid-base balance? Well, in the article that I posted too, it talks about how they're the first defense. Buffers are always in our body, though, that bicarbonate response, that, and there's different ones. In our red blood cells, in our bloodstream, we have protein buffers. So they help bind with the hydrogen and neutralize it, right? They bind together and they get rid of it. Carbonic acid, and it's really interesting how that's a volatile acid in our blood. It goes into that liquid form in our blood, so that then when it goes to our lungs, it binds with the water, and that's how we get the CO2 in water, so we can blow off carbon dioxide and then secrete water. So carbonic acid in our blood is how CO2 is excreted by the lungs. So we have different buffers. Help maintain pH by binding with hydrogen ions to decrease blood acidity, or release hydrogen ions to increase blood acidity and balance the acid-base balance in our body. It's called homeostasis, right? We all have to do our, we're all balanced, okay? We're all sitting here and we're between 7.35 and 4.5. So we think our lives are out of control, but we have to pay attention, be in tune with our inside, right? Our blood sugars are probably right there between 70 and 100. Our thyroid levels are stable, right? See, you thought everything was out, but really it's all in control. You're sitting here and your blood gases, you're between 7.35 and 7.45. Okay, buffers work quickly, but they're limited. If you get way out of whack, you know, they're not going to be able to compensate. So how do our lungs that are our secondary defense, how do our lungs compensate? Our lungs can kick in more quickly, okay? Because we can breathe faster, we can breathe slower. Speaking of like yoga and stuff, there's a like breathing exercises you can do. And I know this person who teaches like this 3-part breathing to music, where you use your upper diaphragm and then you get your lower abdomen and then you exhale. It goes like 1, 2, 3, 1, 2, 3. And she has people doing it to music. And I've been in this circle, right, of these people doing this breath work. Oh, it's breath work, which is good because I don't think we pay a lot of attention to our breathing, do we? But pretty soon I was getting tingly, right, really tingly. And my hands started getting really tingly. And I'm like thinking, what is she teaching these people to do? She's teaching them to hyperventilate, and everybody here is having respiratory alkalosis because they're breathing off all their CO2 and we're all getting high, you know, breathing this fast. I mean, sure, we're over oxygenate, you know, maybe it's good for a short period to hyper oxygenate your brain cells and stuff and feel like that, woo, I just did a breathing exercise and got extra oxygen. I'll do it sometime with you guys, and, you know, you'll all start to, you know, it's really funny how you start to get that tingling and everything. And you're like, what's going on here? Alkalosis. Okay, so how do the lungs help acid-base balance? So you increase your respiratory rate to blow off the CO2. You get rid of the carbon dioxide, right? The carbon dioxide. And there's really cool, it's really cool how the carbonic acid, the H, when you get the H with the CO, you know, and the 3, and then you got carbonic acid, and then it breaks off into H2O and CO2, and you exhale the CO2 and you excrete the H2O, and some of that is the byproduct of the lungs too. We do exhale water with our lungs too. We're going to decrease our respiratory rate to retain some of that CO2, so we can regulate with our breathing. So, you know, if I start breathing really fast and I'm blowing off too much CO2 in time, I'm going to decrease the respiratory rate back to retain CO2 and compensate back for it. So this can, you know, it quickly steps in to help correct imbalance. We exercise, we build up lactic acid. What do? We breathe faster, right? Kidneys, how do the kidneys help maintain acid-base balance? The kidneys are so amazing. You know, it's so cool. So Jesus turned water into wine, right? Our bodies turn blood into urine every day. Think about that next time you pee, right? Amazing body you have there. Blood into urine. How do the kidneys help maintain acid-base balance? Gets rid of hydrogen, right? So, or through that buffer system, right, we can retain bicarb production with the kidneys. So retain or excrete bicarbonate ions, retain or excrete hydrogen ions. But the only problem, they're the third thing to kick in, and it takes about 2 to 3 days for the kidneys to be able to compensate and be able to start this process. Okay, so they come a little later to the party, to the acid-base balance party. Acid-base norms. Okay, here's your numbers. Tattoo time, right? Go ahead, write them. 3.5 to 4.5. So if it's less than 7.35, you're acidotic. Greater than 7.45, alkalotic. CO2, pay attention. 35 to 45. Where have we seen those numbers before? Right in the pH. Okay, so we got this. 7.35 to 7.45 for pH. Carbon dioxide, right? Or like I like to say is the acid, right? 35 to 45. We just dropped the 7s. We got 35 to 45. Now we know we've got memorized 2 of our values. Oxygen, you want at least, in the artery, when you draw, it's going to be between 80 to 100. Some of it's going to be dissipated and absorbed. Poor oxygenation in a blood gas, less than 75. Pulse ox should be above 94. But when we're drawing blood, 80 to 100. The bicarb on a blood gas between 22 to 28. Some sources you'll see 26. Okay, I think the article I gave you says 26. On a test, it shouldn't be in the gray area. It should be either high or low. So 22 to 28. You know, every place you go, you got to look at the normals for the lab that they use at that hospital. So, and then base excess, -2 to 2. So whether there's a strong acid, so there's more base or there's less base. I like to also talk about the anion gap, so we'll get there with that too. And that's more on the electrolytes and looking at the positively charged electrolytes and the negatively charged electrolytes. And so acidosis, less than 7.35 with what types of diseases? Diseases that are going to affect the lungs, right? Because they're not oxygenating well, they're not able to get CO2 out and excrete it, so they're retaining CO2, so they're going to be acidotic. But there's other types, okay? So, but there's only 4 total, because it's either going to be lungs or kidneys. So lung issues, right, are respiratory acidosis. Kidney and other issues are metabolic acidosis. So you either have respiratory acidosis or respiratory alkalosis, or metabolic acidosis and metabolic alkalosis, those 4 alterations. Okay, you can have both respiratory and metabolic, or you can have mixed, but there's only those 4 in combination. Okay, so everybody say that with me. Respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. Okay, so if the CO2 is high, the pH is down, respiratory acidosis, because the lungs get rid of the CO2. The lungs regulate the carbon dioxide, right? We exhale carbon dioxide through our lungs, or we retain it through our lungs. Causes. Hypoventilation. I give somebody too much narcotic and they're not breathing, right? Somebody falls into a pool and they're not breathing. Somebody chokes and the hot dog's blocking their airway. Your asthma, your COPD, your pneumonia, your tuberculosis, all of those things, right, are going to cause, well, hypoventilation. So you got that ventilation mismatch. You have stroke and the person's not breathing because their head injury is causing them not to breathe. Okay, what's your patient going to look like? They're hypoxic, right? So you're right, they might be anxious, or they might have a change in their level of consciousness. They might be unconscious. Decreased respiratory rate and depth because they're retaining CO2. Altered level of consciousness. They might have a headache, right, because their pH is off. Blurred vision, loss of consciousness. the cells aren't getting enough oxygen and you have an acid-base imbalance, your body does not want to be out of that 7.35 to 7.45 range. So if you get extremely acidotic, there's cell death. Cells die, they don't have oxygen, they're in an acidotic environment, and they die, and the person dies. Metabolic acidosis. You don't have enough bicarb, okay? So there's ways that the body loses bicarb. So you're either gonna have decreased bicarb or too much acid from other sources that aren't CO2, right? So if you're not putting on enough bicarb, reduced HCO3, it could be sepsis or lack of oxygen or cardiac arrest, or the person who took aspirin, or they're starving, because remember, if you don't have enough carbs, your body is going to break down fats to get energy, which people do when they don't eat any carbs and make their body break down fats. And then a byproduct of that are keto acids. And then, right, you get ketoacidosis. Not so super, well, and if it's from diabetes, then it's not so super diabetic ketoacidosis. Oh, you know, the sound of it is something quite atrocious, right? So renal failure, diarrhea. With diarrhea, you're losing bicarb out your butt. Okay, presentation, what are they gonna look like? They're not gonna feel good, right? They're gonna be pretty wiped out and weak, fatigued. They could have electrolyte imbalances that lead to dysrhythmias, heart rate low, hyperventilate. Think about Kussmaul breathing. Kussmaul breathing is a very specific type of breathing where they're breathing fast to try to get the CO2 out. So the patient's compensating for the metabolic acidosis. So they're breaking down fat, they have ketoacidosis, and they're breathing fast to try to get rid of CO2 to compensate immediately. So respiratory should compensate quickly for metabolic acidosis. They should be hyperventilating if they're metabolically acidotic. Okay, respiratory acidosis. There's your picture of your person, and metabolic acidosis, the picture of your person. So ways that you can lose bicarb and have too much acid. And, okay, so the two types of acidosis, metabolic and respiratory. pH is above 7.45. We're talking alkalosis now, too much base, because it's all about the base, right? But now we got too much. So if you have respiratory alkalosis because you're doing breath work with Amy, right? And you're going, and she's playing this beautiful music, but she's coming around making sure everybody's breathing fast and keeping it up. And you're gonna blow off all your CO2, and your CO2 drops below 35, and you get all that numbness and tingling, and you're alkalotic. Hyperventilation, anxiety, fever, and if you're, if you're really hypoxic and you're breathing faster, once the aspirin absorbs in your body, that triggers because you have that increased acid in your body, then you're going to breathe fast. So initial salicylate overdose and increased metabolic rate, right? When you're running and running, you're breathing really fast. Those kind of things. Presentation, tachypnic. So people with anxiety disorders, or, we used to have them like breathe into a paper bag. Now we'll just have them to take slow, deep breaths and everything. Palpitations, dizziness, numbness and tingling, tremors, loss of consciousness. And metabolic alkalosis. One of the ways people can get metabolic alkalosis, we think about like if somebody is really acidotic, you know how they'll give like bicarb in codes? They'll be like, oh, give them bicarb, but you don't want to overcompensate. They can give acid, but very, very carefully in ICUs, because acid, it's very hard to give acid. It's hard on the veins and stuff. So with metabolic alkalosis, one of the ways people out there can also ingest too much bicarb is baking soda, right? Do you ever see on the side of the box where it says may take as an antacid? but don't take it too long, don't take it too much. Well, that's why, because, and I actually had a nursing student once, I said, who would be so silly as to keep taking too much sodium bicarb? I mean, when they, you know, it's like, who would be so silly as to not eat any carbs, you know, and you got somebody doing that keto diet, you know, but the thing is with the keto diet, the thing is we probably eat way too many carbs, right, in our society. Everybody's like carb starved. We want, you know, we want sugar. So usually when people are limiting it, they're eating more of a healthier amount, not hopefully not eating any carbs and causing ketoacidosis. Same thing with taking baking soda, right? A dose here and there isn't going to be bad, but like I actually had a nursing student that was taking a lot of it. She didn't realize, and then she learned this, and she's like, actually, I was this one silly enough not to realize that this could occur. So spread the word. Don't overdose on sodium on baking soda. You'll get alkalotic. But if you're vomiting up stomach acid, if you have an NG in as a nurse and you're suctioning out all these secretions out of your patient, they're losing a lot of their stomach acid, right? That's when we have NGs in patients and we check aspirates, we usually give it back because we don't want to disrupt that acid-base balance. Aldosterone levels being high, excessive antacid ingestion like the sodium bicarb, the baking soda. Or same thing with Tums and stuff, right? If it's got bicarb, if it's bicarbonate, you know, it's like our natural buffer, right? But we're ingesting extra buffer. So how are we going to present? Confused, decreased level of consciousness, tetany, hypotension, seizures, respiratory failure. And here's your two pictures of alkalosis. So respiratory alkalosis, metabolic alkalosis. They don't look very well, do they? Okay. Let's move on. And I'm all queued up here. Make co-host. Oh, I'm already a co-host. Okay, never mind. Okay, there you go. Now you can sing it, right? It's all about the base and acid. Okay, so remember, important information to remember. The relationship, okay, between potassium and hydrogen. So potassium, K, right, with a plus sign, positive. Cat ion, we feel positive about cats. We love cats, okay? Do you love cats? Yes, we feel very positive, right? Potassium is a cat ion. Hydrogen has a positive charge to it, okay? So one way that when we are producing too much hydrogen in our body, so potassium likes to be in the cell. That's why potassium levels 3.5 to 5 in the blood, because all of it should be in the cell. So it's only 3.5 to 5. So when your hydrogen goes up in your body, in your blood, potassium will come out of the cell and hydrogen can go in the cell to try to maintain some balance. So if potassium's coming out of the cell, it's going to go up above 5. We're going to be hyperkalemic. That's not good because we need, you know, potassium and sodium is how we control our electricity in our heart, right? There's 2 organs in the body that run on electricity, brain and heart. So if we have big changes in our potassium level, causes arrhythmias, can cause death. So just remember that there's a relationship between potassium and hydrogen. As we get acidotic, potassium is going to move out of the cell. So with acidosis, you're going to get hyperkalemia. We say kalemia because of the K for potassium. Don't ask me why. Tom probably knows why. Is it Greek or is it Latin or something? Potassium with a K, right? But KCl, potassium chloride, okay, so potassium is a positive. So we like potassium, it's a cation, it's got a positive charge, and it has this relationship with hydrogen. As we have increased acidosis, increased hydrogen in our body, the potassium is going to move out of the cell to try to make room for those hydrogen ions to move into the cell. Okay. Moving in and out of cells. So if there's alkalosis, the hydrogen is going to come out of the cell and put the potassium into the cell to try to get more acid out of the cell, which will make our potassium low. So it can go either way. So if there's acidosis, hydrogen, right, we're going to have hyperkalemia. If there's alkalosis, then you're going to have hypokalemia. Same in the kidneys. If one is retained, the other will get excreted, okay, with potassium and hydrogen. Metabolic acidosis. What are the two alterations seen on an ABG seen with metabolic acidosis, okay? Alterations. What's your pH going to be with acidosis? What's your pH? Corey, what do you think your pH will be? Below what number?
It's going to be below, well, if we can tolerate 7.35, it would be below that, but I would say below 7.4.
That's the, yep, that's as low as it goes. Below 7.35, acidosis, exactly. Okay, so our pH is going to be abnormal. And with metabolic, we're talking what for kidneys? What is the, Stacy, what is it? What lab value on the ABG are we going to look for?
I'm not sure.
What's HCO3?
Bicarbonate.
Yes, bicarb, okay? And what's the normal bicarb level?
22 to 28.
22.
22 to 28, yes. So how is it going to alter with acidosis? With metabolic acidosis, we're
going to be low.
Yep, we don't have enough base, right? So it's going to be under 22. Okay, so if we're looking at blood gas and the pH is below 7.35 and we don't have enough base and the base is below 22, the bicarb's below 22, we have metabolic acidosis. Metabolic acidosis, okay? So we know that either the body's producing too much acid and it's using up all the base, or we're losing base somewhere, okay? Yep. Very good, guys. So some of our alterations: too much acid production, bicarbonate loss or excretion. So, you know, with kidney failure, right, your body's not getting rid of all that byproduct and everything. So that's going to cause metabolic acidosis. We talked about diarrhea being a reason to lose too much bicarb. Increased chloride. This article, that's why I love this article, because it's Infusion Nurses is the publisher. And it talks about how if you give sodium chloride, chloride is a negative, right? Negatively charged. So if you're giving like fast boluses to replace fluids, you could actually be creating metabolic acidosis. So remember, this is really important, because these guys who are in your class that have seen this before, they know how much some of the other instructors like to pull in the electrolyte imbalances and how it affects acid-base balance, right, Esme and Jess? And yeah, so refer back to these slides as examples of how, you know, different electrolytes can affect acid-base balance, okay? And that, like I said, that article that I posted is one of my favorites, because I feel like it just really explains each of the three ways our body compensates really clearly. I think especially we focus so much on lungs and kidneys, we forget about those natural buffers too, and that gets a little confusing. So don't let it, okay? Just, I feel like that article, I almost want to get it out and read it to you as a bedtime story or something, you know, like, let's read about acid-base balance. Okay, metabolic acidosis. Common causes of metabolic acidosis. DKA, that's the big one, right? Lactic acid buildup from decreased oxygenation, perfusion, cardiac arrest, renal failure, diarrhea. With diarrhea, you can also lose bicarb. Pancreatic fistulas that lose bicarb, ileostomy, drainage. How does the patient with metabolic acidosis look? How might they be breathing, Alicia? How might the person with DKA or with metabolic acidosis compensate and breathe?
Maybe by hyperventilating.
Yep. They're going to breathe fast. They're going to blow off CO2. With DKA, what's the term for that? And their breath actually smells fruity and everything. What type of breathing? Kussmauls, yes. Kussmauls, or L''S, Kussmauls breathing. Did I spell it right? Oh, this one just says MALS. Maybe it doesn't have a U. Okay. Metabolic acidosis. How do lungs try to compensate? Try to blow off CO2, try to get rid of that acid. Keep that pH, keep that within normal limits, between 7.35 and 7.45. So if I breathe fast enough and my pH is 7.35 to 7.45, I've compensated because I was acidotic and I started breathing and I got rid of all that CO2 and I brought my pH within balance. Interventions done to correct the balance. We're not going to overthink it, okay? Identify the cause and fix it. So monitor fluids, vitals. Carefully giving sodium bicarb to correct the acidotic state if you can't fix it fast enough, okay? If the person's coding and you've got documented acidosis, it's going to be very difficult to resuscitate them if their acid-base balance is way off. So in extreme cases, you will give bicarb. But you want to make sure that you know they're acidotic. You don't want to overdo the bicarb and have them be too alkalotic because it's not good for the body to go one way to the other real quick. Metabolic alkalosis, two main alterations seen on the ABG. So if they're alkalotic, what's their pH going to be, Vivian? With alkalosis, pH is going to be above?
7.45.
Exactly, you got it. Okay. What else is going to be off with the metabolic? So this is metabolic alkalosis. What lab would we look at to identify? Rachel?
Did you say what lab are we looking at?
Yeah, so we're looking at the ABG, and what part of that tells us metabolic?
The pH.
Yes, the pH tells us if they're alkalotic or acidotic. We said the pH is above 7.45, so we got that. We know they're alkalotic. What's going to tell us if it's a metabolic problem?
Bicarbonate level?
Yes, yes. So if it's alkalotic, what's the bicarb going to be? Above what?
22?
28.
28?
Yep, above 28. Okay, it's going to be too high. Yep, because the bicarb is the base, right? So we got too much base, and that means metabolic. Okay, remember CO2, the carbon dioxide, are the lungs. The bicarbonate is the kidneys, and how the kidneys, so our kidneys excrete bicarb. Retainer excrete bicarb, retainer excrete hydrogen. Lungs retain or secrete CO2, carbon dioxide. Okay, so we're going to see with metabolic alkalosis, we're going to see pH above 7.45. We're going to see the bicarb above 28. Some labs will say 26. Alterations that may lead to metabolic alkalosis. So if you're losing acid with an NG, or draining out hydrogen, or hydrochloric acid is draining out, you have an increase in bicarbonate for some reason, like you're the person taking the baking soda for fun, because you're like, oh, my stomach feels a little off, I'm going to swallow a bunch of baking soda. Common causes of metabolic alkalosis: vomiting, gastric suction because you're losing hydrochloric acid, hypokalemia because remember, if the potassium's low, then hydrogen's going to come out of this because hydrogen's going to go into the cell, right? And the potassium is going to come out of the cell to try to normalize the potassium, and then you don't have enough acid in the blood and you're going to be alkalotic. If you're alkali ingestion, too much bicarbonate administration makes you alkalotic. Too much base, because it's all about the base. What does the patient with metabolic alkalosis look like? Confused, decreased level of consciousness, hypotension, tetany, seizures, respiratory failure. And what do you see? You're going to see the calcium is going to be low. That's what causes the tetany and everything, because calcium is also cation. So alkalosis causes the calcium to bind with the serum proteins. Remember how I said there's buffers in the blood too, those serum proteins in the blood that are our buffers? So thus it reduces the amount of active calcium in the blood. So it's just another example of how electrolytes then also connect and factor in with acid-base imbalances, okay? So more about alkalosis, metabolic alkalosis. How are the lungs going to compensate? Shelby, what do you think? So you have metabolic alkalosis, you have too much base. What are the lungs going to do with that CO2? What do they want to do to try to correct that high pH?
Would it be like hyperventilate? Like, are they're hyperventilating, right?
If I let's think, okay, if I hyperventilate, I'm getting rid of acid. If my pH is too high right now, the acid brings the pH down, right? So my body's going to want to keep that acid to help balance this, right? So if my body wants to keep acid, what is CO2? I like to call it.
Right. Carbon dioxide.
CO2 raises the acidity, so it's going to lower the pH, right? As CO2 goes up, pH comes down. Okay, it gets more acidic. So how do we increase CO2? What do our lungs do to increase carbon dioxide? Brett, what do you think the lungs are going to do?
Hypoventilate? Oh,
What's that, Sydney?
hypoventilate?
Yes, exactly. With people with metabolic alkalosis, their respiratory rate's going to go down. They're going to retain CO2 so that they're retaining that acid and compensating. Yep, hypoventilate in order to retain. That should say retain, not remain. The CO2 will remain in the lungs and help the pH back to normal limits. Interventions done to correct this imbalance. Identify the cause. If you got an NG that's draining out all the person's acid, you got to replace that, right? Monitor electrolytes, monitor vital signs, respiratory rate, eyes and nose. So where are they losing it? What two alterations are seen on an ABG with respiratory acidosis? Okay, now you guys are going to know this because we were just learning about our exemplars, right? What two alterations are seen with respiratory acidosis on your arterial? So you get arterial blood, you're sending it off to the lab, and they come back and they're giving you the pH, they're giving you the CO2, they're giving you the bicarb, and they're giving you the oxygen saturation in the arterial sample, okay? And we're focused on pH, CO2, and bicarb. That's really what, hopefully the oxygen's okay too, right? But in terms of acid-base balance, those are our three numbers. So Mariah, with acidosis, what's the pH going to be?
7.35
or less, right? So below 7.35. Yep, not enough. Okay, low pH. Okay, what else is going to be abnormal? What value is going to tell us it's respiratory? Nathan?
The bicarb be low also.
Okay, what controls bicarb? What organ secretes bicarb?
Kidneys.
Kidneys. What organ? What other organ? What's respiratory? What organ is that?
Lungs.
Yes, lungs. Nathan, what do the lungs get rid of?
CO2.
Or retain, right? So in pneumonia, if I can't get rid of the CO2, what's my CO2 going to be in my blood? Above what would be abnormal?
Above 45.
Yes, you got it. Okay, you got it. You got it? Nathan?
Yep.
Don't forget it. Okay, don't anybody forget it. You got it? Okay, so if I'm not able to breathe well and I can't get rid of my CO2 and my CO2 level goes above 45, my pH is going to go down below 7.35 and I'm going to be acidotic and I'm going to have respiratory acidosis. And you're going to get that blood ABG result, and you're going to look at it and go, pH is less than 7.35, it's acidotic. CO2 is above 45, it's respiratory acidosis. Boom, drop the mic. Okay, it's that simple. Okay. pH less than 7.35, CO2 greater than 45. What are acute respiratory acidosis causes? Are exemplars basically, right? Pneumonia, asthma, COPD. Also, if they're on a PCA, patient-controlled analgesia, and they're pushing the button too much, and they're over-sedated, and respiratory drive is down, and they're retaining CO2, and they're getting too much acid, okay? Chronic respiratory acidosis causes COPD, cystic fibrosis, not having good musculature, like multiple sclerosis, to not be able to breathe, other neuromuscular diseases or stroke. Respiratory acidosis, what does the patient look like? Headache, irritable, level of consciousness is altered, weakness, cardiac arrest. Interventions to correct the imbalance, right? What do you think it's going to be? What are we going to do, Jess? We're going to Jess Elledge? Right?
Repeat it. Sorry. She's having problems with her sound earlier. Her microphone.
Yeah, I forgot, Jess. Sorry. That's okay. I know you're there. Identify the cause and fix it. Respiratory assessment, increase respiratory rate, right? Pulmonary therapy, ventilation. Get those lungs opened up and getting that CO2 out of there. Okay, respiratory alkalosis. We got to calm them down, right? They're probably going to be breathing too fast, right? Or something, right? That's when they're not. Okay, so pH is going to be what? Isela? With alkalosis, what's the pH going to be?
Above 7.45.
Exactly. And what other lab value are we looking at for respiratory?
CO2.
Yep, CO2. With alkalosis, what do you think the CO2 is going to be?
Greater than 35.
Greater than, what's the normal range?
35.
35 to what?
45.
Yes. So if it's alkalosis, what's the CO2 going to be?
Greater than 45.
No. That's too much acid. Remember, it's carbon dioxide. Am I getting confused? Okay, so CO2 is acid, right? So alkalosis, what's the CO2 going to be less than?
Less than 35.
Yeah, did she already say that? Because I didn't hear it, right? You said 35, but I didn't hear less than 35. So I'm sorry if I confused you, Isela, but everybody's got that? See, it's going to make sense when I get to the acronym ROAM. You want to go to ROAM and make sense of it all? I want to go to ROAM, but we can't because there's a pandemic. They won't allow us in, right? So respiratory alkalosis, high pH, alkalotic, right? It's too much base and not enough acid, so our CO2 is low because we're probably breathing too fast or something. We're probably blowing off our CO2. Common causes of respiratory alkalosis: hyperventilation, fever, anxiety, aspirin early when you first ingest aspirin, hyperventilation with a mechanical vent. If you're overventilating with a vent, you're going to be blowing off too much CO2 also. What does the patient look like? They're hyperventilating, they're dizzy, they might have the tetany and the numbness and tingling around the mouth and everything, decreased level of consciousness. Interventions: identify the cause, fix it. Why are they blowing off too much CO2? Why do they have respiratory alkalosis? And fix that problem, okay? So how you're gonna interpret your blood gases. First, you're looking at that pH. Is it too low? Is it too high? Is it just right? So if I have a pH of 7.25, right? I clicked too many times. We go right there, we go, okay, 7.25, acidotic. CO2, if it's 52, what is that, Sydney?
Can you repeat the question?
Yeah.
Stop.
So our pH is 7.25. We know that's acidosis. The CO2 is 52.
That's acidosis as well?
Yes, because it's too high. The CO2 is too high, right? It's above 45. So what type of acidosis do we have?
Respiratory.
Exactly. Respiratory acidosis, because the CO2 is controlled by the lungs. That's why it's respiratory. And then we can look at the bicarb, right? And it's 25, so it's normal. So then we know for sure that we don't have a combo, right? It's not metabolic and respiratory. So the kidneys haven't kicked in yet, right? They're not compensating. They're not trying to retain bicarb, and our bicarb level is not too high. It's within normal limits. So this is respiratory acidosis without compensation because the pH is abnormal and the bicarb is normal. Which one matches the pH? Right? Respiratory acidosis. Okay, so there's more practice in here. Like here, pH is 7.52. So what is that? That's too high, right? 7.35 to 7.45.
Metabolic alkalosis without compensation.
Let's go ahead and we're going to take a break, okay? Come back in 10, please. Hi, this is Penny. Okay, is everybody back? So, to go ahead and practice this, we have a patient, kind of lethargic, right? And we see this pH. So Shelby, what do you go ahead and take it. What do you think? You ready to take one? See how you do? You want to ask anybody for, if you want, you need to ask a friend for help, pick a friend to call on. So
I'm
remember,
just
yeah, we're going
trying
to
to figure out if it's acidosis or alkalosis and if
right.
it's
So
metabolic.
first, so yeah, pH 7.52.
So it's acidotic or alkalotic at that point. Alkalotic. Ugh, yes, that word.
Okay, so what's the normal for the pH?
Between 7.35 and 7.45.
Yes. So is this higher or lower?
High.
Right. So if the pH is high, what's the term for that?
Alkalotic.
You're right. Alkalosis. Yes, exactly. Okay. CO2 is 44. What's normal for CO2 value?
Between 35 and 45.
Yep. So what is that 44? And you guys just froze on me. Come on. Good places. So I went on break and then Tom, then I just lost internet again. Okay. So sorry. I don't know why my internet cut out. Let me bring that up real quick. Okay. So here we were. And you were telling me that normal CO2 is 35 to 45. So this CO2 is? Are you still there, Shelby?
Yeah, I'm still here.
Okay, there you are.
I think Selena was helping and she said it was normal.
Yes, she's a good helper. Yeah, it's between 35 and 45. It's on the high end, a little high, you know, but it's still within normal limits. So CO2 is normal. So is it respiratory? No.
No.
Good. Okay, our bicarb's 32. What's normal bicarb?
Is she frozen again?
I know, I am frozen again. Oh, you gotta be kidding me. Why does it do that? We went on break, we come back, and then it freezes? That's not fair. Life is not fair, right? But it's not, you know what? But life is not fair for everybody, so it must be fair. If it's unfair for everybody, then it's fair, right? It's called the shared suffering of humanity. Okay. So the bicarb normal is?
22 to 28.
Yes. So what is this bicarb?
It's high, so
yes.
it's alkalosis.
Yes. So what does the bicarb tell us though? What kind of alkalosis?
Metabolic.
Metabolic alkalosis, you did it. Is this your first time interpreting a blood gas?
Yes.
Yay, I got to be here first. Woohoo! Isn't that fun? It is, isn't it?
I mean, it's nice to understand it a little bit better when actually looking at it when I'm in like the clinical setting. So
yeah, and especially when you see this person who's been in pain a lot, and then he starts having tetany and stuff, and you're like, what could be going on? And the doctor is like, go get a blood gas real quick. And then you get a blood gas and you look at that and you're like, oh my gosh, that's metabolic alkalosis. And they look at you like, whoa, that was good, right? And you're like, yeah, I know my blood gases. I know my blood gas interpretation. Yeah, and you really see, so we're going to go to the clinical setting and you're going to really be interpreting these gases and seeing this. And it's going to be fun. Yep, metabolic alkalosis. Okay, but that's not all, folks, right? Okay, Sarah, you're up. Take it step by step. What's that pH?
So that's acidotic.
Yes, because it's below 7.35, right?
Mm-hmm. And then the CO2 is 40, so that's normal or okay.
You're right, it's between 35 and 45. 40 is right in the middle, yep.
And the bicarb is low.
Yes.
So then it's respiratory.
Bicarb. Bicarb is too low.
Mm-hmm.
CO2. CO2 is controlled by what? The PCO2 is the what organ? Carbon diacid or carbon dioxide is the what organ?
The lung.
Yeah. Bicarb is the what?
Stomach.
What acid is produced by the stomach, but what controls bicarb and hydrogen? Somebody said it in the background.
The kidneys.
The kidneys.
Yes. Yes. Okay. So is that
can I just
bicarb?
ask?
Uh-huh.
Sorry, so between the two, between the PCO2 and the HCO3, one of them will be normal, and that's how we declare whether it's metabolic or respiratory. Is that correct?
Correct.
Okay, that makes way more sense.
Yep.
It'll be, wait, quick question to clarify that. It'll be normal unless the body has started to compensate.
Exactly. Okay, so I will explain compensation after we get the basic abnormals, okay? Yep, that's the next step, is then once we identify like, okay, that bicarb is too low, right? The bicarb is below 22. So we don't have enough base, okay? Just remember the CO2 is the acid, right? So if you have too much acid, you're going to be acidotic. So if the CO2 is high, the pH is going to be low and you're going to be acidotic. If you don't have enough acid and the CO2 is low because you don't have enough carbon dioxide, then your pH is going to be high and you're going to have respiratory. And the CO2 is the lungs. The CO2 is the respiratory. We breathe in and out, right? We breathe in oxygen, we excrete carbon dioxide. Breathe in oxygen, secrete our carbon dioxide. Carbon dioxide is the lung function. The bicarb is the kidneys. We excrete hydrogen and bicarb and retain it through our kidneys, okay? Kidneys is metabolic. Kidneys is metabolic, respiratory is CO2, okay? Got it? Okay. And from here, I want you to keep studying it, okay? I'm going to give you some practice ABGs. I'm going to give you a link for that cute little rnnursing.com girl that's got the Southern accent, and she's going to sweeten it with some honey, and she's going to tell you all about her ABGs, right? And you're going to be like, oh, why didn't Miss Erickson teach us this way? I told you the exact same stuff. I just didn't do it as well. Okay. No, it's because you hear it again and again, and then it sticks. Okay. You'll get it for a moment, and then it, just keep it straight. Okay. Keep studying it, get it right down. You'll get there. Don't worry. Everybody gets there. Okay. But does that make sense? So pH is low for the second one. It's below 7.35. Acidosis. CO2's the CO2, the carbon dioxide is normal. We know it's not respiratory. The bicarb is too low. We don't have enough base, right? So we know it's metabolic acidosis. Metabolic acidosis right here. This could be our person with diabetes. So how do we remember that when the CO2 is high, the pH is down? Right? And when the bicarb is high, the pH is high. Okay, so when the CO2 is high and the pH is down, or the CO2 is low and the pH is up, CO2 opposite, right? CO2 is the lungs. So we say respiratory opposite, CO2 down, pH up, CO2 up, pH down, because of the lungs. So RO, Rome, right? Respiratory opposite, but with metabolic, with the bicarb, bicarb's up, pH is up. Base up, pH up. Base down, pH down. Metabolic equal. So you see how we get so fancy in nursing, right? Oh, respiratory opposite, metabolic equal. Okay? Like I said, you'll watch the video during the week and you'll hear the same thing over too. That's what we mean. If you've ever heard, remember Rome with blood gas interpretation, that's what we're talking about. Respiratory, you'll see opposite numbers, metabolic equal. There's another way of breaking this down too, and that's the tic-tac-toe method. So if your pH is down and your CO2 is up, we know that's respiratory acidosis. If your pH is up and your bicarb's up, we know it's metabolic alkalosis. And then the tic-tac-toe method, we just have acidic, normal, or basic in our tic-tac-toe columns. If the pH is, you know, we assess the pH and the CO2 and the bicarb, and we place them in one of those three columns. So if our pH is 7.223, we're going to put that in the acid column. The CO2, the carbon dioxide is normal because it's between 35 and 45, so we're putting that in the normal column. So we don't have a tic-tac-toe there. Bicarb is 15. Normal is 22 to 28. It's too low. We don't have enough base, so it's acidic. So now we've got pH acidic, bicarb acidic. What kind of acidosis is it, Trevor?
Can you repeat that one more time?
Yes. When the pH is too low, it's acidotic, 7.23. The CO2 is normal. The bicarb is too low. So we know, see how we got a tic-tac-toe here with pH and bicarb? What kind of acidosis is that?
Metabolic.
Thank you. I was so afraid there for a moment. I was like, I thought, I could see, I thought you had it in your eyes, and I knew you did, so good. Okay. Compensation, I don't want to go there yet, okay? So again, I'm going to stop here because I want you guys to just get the basics down. Next week, I'm going to give you I call it a mad minute. I give you a bunch of problems, you do them, and then we go back and we review them, okay? So we'll do that next week. I'm going to have you guys presenting next week in your teams. And I'm going to go through some case studies too, myself, with you guys, okay? And we're going to talk about compensation. But I don't want to overwhelm, okay? I want you to, I'll give you some resources to review, do the reading, read the article over and over again. I love that, you know, take some notes on it, kind of get it, you know, between the book and that and everything. I just want to make sure you get this whole concept of how does our body maintain homeostasis? How do we stay between 7.35 and 7.45 for our body's pH? Our body likes to be right in that window for cells, for all the cell functions, because as I kind of connected this for you, electrolyte balance ties into acid-base balance because of the positive and negative charges in our body, right? Electrolytes are exactly that. They're electric, right? They either have a positive or a negative charge. So that then affects positive hydrogen, right, in our body, and they interact. So, you know, that all helps us maintain that balance. Just to kind of wrap that concept up, okay? So don't worry about it if you find it, you know, like you're still in that process of learning it, okay? Just keep reading through it, practice it, look at these numbers, take it step by step, and it comes very quickly once you get it. It's a memorization thing. Memorizing pH numbers, normal ranges, lab values, but have fun with it, because it's really fun, and it's fun when you see the patient and you know what that blood gas is going to show. It's like, oh my goodness, how acidotic are they going to be? You know, so, okay. So now let me talk about what the assignment's going to be real quick, and I'll let you guys go. In Blackboard, I posted your teams. Okay, so go into Blackboard. I'm trying to find it here. And okay, good. Okay, so here I got the assignment here. And I want to zoom in a little bit so you can see it, okay? So we've got our 4 different case studies. I kind of got you started. There's lots of great resources in your book. There's you know, care plans, and in Walter Kluwer's, there's interactive case studies, and there's different examples. Check out medical terminology also, because one of these is from that book. So you know, there's 32 of you. I split you into 8 teams of 4. You're going to be looking at what would be the medications, but be specific. Don't just tell me corticosteroids. Give me a med and why that med's being given, you know, and what the dose would be for that patient, and labs and diagnostics. Give me those ABGs, right? What you know, if we did a blood gas, what would it be? Give me the why. Why are they in that medicine? Why would that lab be abnormal? Why would that chest x-ray look that way? And then you're going to put together this formatted assessment page. And guess what I did for you guys? Okay, I'm really trying to help you. I know when you first start doing assessments, you're like, what are all the things in each box I got to assess? I gave you like an outline in that concept map assessment. I gave you 5th semester's old, like one of the 5th semester students put together like a yes, no kind of answers in each box, because they had to do like 5 or 6 patients on their assignment and they didn't have time to write out everything. So she developed this and they let them use it. But I'm letting you get a sneak peek at it so you'll know more of what to put in each of the boxes of the assessment on your concept, you know, on your assessment page for your clinical paperwork. So that's one of the attachments too. So that's going to really help you to identify the different assessment findings that you want to include on your case study. So you're developing this. You're making up what you would see in a patient with COPD, in a patient with tuberculosis. What do the secretions look like? What do the lungs sound like? What are they eating? Because, you know, are they kind of not eating well because of their work of breathing? You know, just you create it. And you can make it interesting. You can come up with funny names. You can, you know, come up with funny, like, you know, things, beliefs, you know. So work together as a team. Notice that A, B, C, D, right? So then the prioritization page is what's your highest level priority diagnosis? What's your lowest one? Give me 4, okay? You don't have to get into how do they relate to each other or anything like that, or big rationales on the concepts and all that. Just give me top 4 diagnoses and why they're 1, 2, 3, 4 in your patient. What was the big problem, you know? And then the care plan, pick 2 diagnoses, top 2 diagnoses. You're going to give me the diagnoses with the assessment findings and everything. Be specific about what you're seeing in that patient, okay? Really paint that picture for me so that assessment's jumping off that page and I can picture that patient. I know exactly what that patient's going to look like. And then give me the goal, a good, smart criteria goal that we're going to be, that anybody could walk in and measure, you know, and be able to evaluate. And then those, give me 5, right? Interventions, independent, collaborative, assessments. How often are you going to continue to assess? Just don't say assess lungs for every 4 hours, right? What is the respiratory assessment? What am I looking for, okay? Teaching, when to call the doctor, right? Respiratory rate greater than this, patient, you know, change the level of consciousness, oxygen saturation below 85% and going up, you know, if your O2 order is from 2 to 4 liters, if the patient's requiring more than 4 liters, you're going to call a physician, right? Notify him of that change. So I know you're new nurses, right? I'm not expecting you to know this stuff. If you haven't been in the hospital taking care of patients, how would you know? And how do you know what the evidence-based practice is? Use your resources. You're going to look it up. You've got Walter Kluwer's The Point. You've got the concepts with the exemplars. You've got Picmonics. You've got interactive tutorials in The Point. You've got care plans in the back of the chapters of your reading assignments that have care plans. COPD, there's great care plans in there, okay? So this is going to show me if you're reading those resources and understanding them to be able to put this together and come and present it. Also, I would love for you to run through this as a team and practice your presentation so that you can kind of see it come together and know if any, you know, so you know what your teammates are doing. Because this is I like to give 1 grade for a team, you know. So I like to see that everybody's participating as a team. Put your names on the slides that you're contributing and be ready to be able to present on those slides. So that as I'm pulling up that slide, you know, and your name's on it, you're the one speaking. You know, you're going to come off mute and you're going to talk on that. And the next person, so it all comes together nicely. Okay? You don't have to put a lot into the backstory. Don't give me patho. I did the patho, right? Whatever I missed in the patho, you're going to be doing in your reading. So you don't have to go into what COPD is or what labs they're going to do. Just tell me your patient's findings, okay? But tell me why they're abnormal, you know, briefly. Like, we're going to look at the white blood cell count with pneumonia because that's a sign that the leukocytosis, because that's, you know, white blood cells fight the bacterial infection. We sent a sputum culture. It was susceptible to Rocephin, so the patient's getting ceftriaxone IV to you know, treat the infection. Okay, just knowing why he's on those meds, what the chest X-ray would show. Okay. So presenting this case study, assessing the patient, identifying the priority diagnoses, giving me the 4 top prioritization page, giving me the 2 diagnoses with the care plan with the goal and the interventions to meet that goal, and that's it. You could evaluate, but you don't have to evaluate. We're not there yet, you know. They'll meet the goal. Airways maintained, lung sounds clear, respiratory rate between 16 and 24, easy, pulse ox 94% on room air, patient ready to go home. Okay, so the 8 teams, we got teams A and B for each case study. Competition on. What we're going to do is, after everybody's presenting, you're going to send me a quick chat. I can save the chats so I can count up the votes later, right? So when I download Zoom to YouTube, you know, that's the video part. I also have a file with the private chats and the stuff. So I can look in there, count them up, see who the winners are, announce them next week. So pride, a little pride on the line, right? So team A, you're going to be doing this 13-year-old history of mild asthma. And you can read more about her case study on page 237 in the chapter 11 medical terminology book, you know, the red one. When you first go in, you don't have to go to content, you know, how there's concept in Walter Kluwer's on The Point. There's the concept resources and the content. It's right there when you go into Walter Kluwer's medical terminology book. So that's Tamara, Mariah, Sydney, and Chanel against Bridget, Shelby, Isla, and Alexandria. Case study 2 is our guy with pneumonia, Kenneth Bronson. Kaylee, Corey, Allison, Hepsera against Robert, Stacy, Nicole, and Monique. Case study 3. I think Monique had to take off early, guys. So hopefully she reads them. I'll shoot her an email letting her know what she was assigned. Okay, and then we have our guy with tuberculosis, Zena, Esme, Selena, Brittany versus Rachel, Alicia, Melinda, Vivian. And then we have, of course, our COPD, right? Brett, Jesse, Thomas, Trevor versus Morgan, Madison, Nathan, Tawny. Okay, and I gave you a little reminder about the 5 interventions. Submit to Blackboard the night before class. Night before class. Be ready to present. 1% of your grade as an outside assignment. I'll be posting a discussion board with the rubric. I also posted the rubric in the Blackboard folder, along with this team assignment document and the clinical paperwork with instructions on the clinical paperwork. So the 4 sections are the meds, labs, and diagnostics, the whole assessment page, the concept map page with the 4 top diagnoses prioritized, the 2 diagnoses with the goal, the interventions as the care plan, as the plan of care for what would be the goal for those 2 top diagnoses. Preguntas, what questions do you have, my loves?
So we have this assignment and a discussion board that's due next class.
You're posting it in the discussion board the week before, the night before class. We're not doing a discussion on it.
Okay, I just want to make sure.
Right, it's not for discussion, it's for you to have access to it. Is it better to do journal? I think journal sometimes it's confusing because if I exit, sometimes you're not able to see it. So I think it's easier in discussion board. And then later, if you had a question, you could always post it. It's not a graded discussion, but it doesn't mean that you couldn't. Oh, is there a quiz next week? I think so. I think that's on our schedule too, because is after next week, is there an exam week 6 on oxygenation? And I like to give the quiz before the test so you kind of know a little what to expect. Okay. Sometimes what I like to do for a quiz, because it works out well, is how at the end of the chapter they have like key concepts at the end of the chapter, and then they have questions at the end of each chapter. Those make really good quiz questions, don't you think? And that shows if you did the reading and you looked over those key concepts and those questions at the end of the chapter. And I want to encourage that. Are you picking up what I'm putting down? If I wanted to prepare for this quiz, I would probably, read that and then read those key concepts and answer those questions. Make sure I knew those for a quiz on oxygenation next week. That sounds good, doesn't it? Now it's not quite so overwhelming. I see. Okay, because that's good review. That helps you prepare for the test. I like to give you, goals and things to keep it focused on what I want you to know. Okay, when you do your reading, remember I told you, focus on the exemplars. There's not going to be questions on lung cancer or pneumothorax or that kind of thing, okay? It's going to be pneumonia, TB, asthma, and COPD. And then assessment and the whole concept of oxygenation and blood gas interpretation. That's what our next test is going to be. But we got another week to prepare, and we're going to be studying our exemplars and case studies next week. It is fun, isn't it? I know you guys are just amazed that 3 hours just went by like nothing. I know. I hate to tell you this, it's really not that much easier in the classroom in terms of 3 hours of class is 3 hours of class. So, okay. If you do have questions afterward and you can't answer it with each other in your teams, email me, okay? I don't want anybody getting frustrated or struggling or, okay? And a lot of times if I get a couple of the same questions, I'll just post an announcement. And I appreciate it, okay? Because I'm constantly working on my communication. It amazes me, what I can forget to say that I thought I said. Communication's hard. At least it is for me. I don't know. Maybe you guys got it down, but you know. Okay. Did you learn something today? Yeah? I hope so. That's why I'm here. Okay. Sorry I can't get you in groups, and I'm not going to get you in groups, okay? I'm going to let you take the rest of the time. You can contact each other. Do you have each other's contact information to get in your teams, right? You got each other's emails, okay? Google Docs usually works well. PowerPoint's great for this. Remember to include your resources. Cite your stuff, right? Don't plagiarize. Okay. Have a great evening. Study. I'm going to post some more stuff. You know, start with the articles, start with the readings. I'll post, you know, YouTube links for the lecture, and I'll post a link for the blood gas interpretation with a nice Southern girl, because she's a great teacher. I love her for a lot of stuff. And I'm gonna go ahead, linked to her ABG instruction are ABG questions and answers, and I can post that as another link too, so you don't have to go searching for it. Lots of resources, guys. We'll play with this. And it's not just me. It's going to follow you to future semesters. So, you know, we're just laying down the groundwork here. Okay. Thank you very much. Have a good dinner. Okay. Sleep good tonight. Take care of yourselves. Stay safe. I hear cooler weather's coming, so we'll just hang in there a little bit longer, right? Okay. Thank you. I'm going to hang if anybody has questions, but you're free to go. It's all
Ms.
about
Erickson, I do have a question, sorry.
Yes, ma'am. Yes.
Can you go over again what's expected for the care plan section?
Yes. So the care plan, let me see if I can find it here. Might be this document. Come on, open, open, open. There. I think it's going to come up here. Come on. I've got it open. My computer's thinking about sharing it. Come on. Why are you guys, you're seeing a black screen, right? Let me try it again. Share screen. We love computers. Okay, so here's where you're going to document your meds and labs. Here is, and there's more labs, right, and giving rationale, just papers. And you can kind of fill it out there and then put it on your PowerPoint. And then here is where I kind of gave you a template for different assessment findings you might consider. You can add different things to this too. Don't just, this is just suggestions. You can put whatever you want. And don't use the, you know, like you could like just erase this and put your stuff in there, but use that template to give you ideas, okay? Here is the concept map page where you're gonna put your top 4 diagnoses and number them, 1, 2, 3, 4, from most. Number 1 is your most important one, the biggest problem, like if pain, if they're in horrible, horrible pain, that might be number 1, because they're not gonna cough and deep breathe, and you know, they're not gonna learn anything for knowledge deficit if they're having too much pain. So you're gonna give me your top 4 numbered. And then here is the care plan section where you're going to give me the top 2 nursing diagnoses, and you're gonna write a SMART criteria goal, and you're gonna list your 5 interventions, and you're gonna like say if they met the goal or not. Just say they met the goal. Yeah. Goal met is fine. And up here, you can fill out those top boxes, or you can, I didn't require them on the rubric. I'm just looking at diagnoses. Okay? So this is the tool I'm having. You can present off of this if you wanted, or you can put these findings in PowerPoint also, however you want to present.
Okay, so that's all within the care plan.
This part is
section.
the care plan. Page 5 is the care plan. So if you got care plan, it's D, right?
Mm-hmm.
This is what I want you to do. I tried to
okay.
just break it up so you guys didn't have to try to figure that all out. If you want to switch with somebody and somebody else is like, oh, I really wanted to do the care plan, will you do the assessment? And you're like, yeah, I'll do the assessment. You can do that. Just email me and let me know you switched.
Okay, thank you.
You're welcome. Okay? You're excited, aren't you, Melinda? You're like, this is going to be fun.
It's going to be great.
Yeah.
Actually, I did learn a lot, so today was good. I have a question. It's not related to today, though, so if anyone else wants to go first, that's okay.
Okay. What else? I froze again. Uh-oh.
All I wanted to say is just I really appreciate the way that you're teaching this, because we've been doing clinicals and we were not given any of this stuff, and the way that you've explained it has been extremely helpful. So I really, really appreciate it.
Thank you.
The only reason I wanted to stay back just to tell you that, because it's been like the last 3 weeks of clinicals have been extremely struggling, because they just gave us all these paperwork and then it's like, okay, have fun, but then they critiqued the heck out of it. So just the fact that you've kind of gone through it and like give us a sample of the brain has been, it's huge. So thank you.
Thank you. I appreciate the positive feedback. We all need that, don't we? Yeah. Thanks.
I really appreciate it. Have a good night.
Thank you.
Ms. Erickson, I just wanted to ask you, so you said for the evaluation of the goal, you said we could just put something like goal met or, you know,
patient maintained patent
Okay.
airway, or yeah, or lungs were clear bilaterally, goal met.
Okay. And then so if it's something where it's not exactly in the case study, is it something that we kind of just
You develop it.
Okay.
Yep.
All right.
You're gonna connect this to it. The findings though, the assessment findings support the diagnosis. The assessment findings that are on the assessment page, you're gonna take from that to create your nursing diagnoses.
Okay.
So that's where your connection is gonna be. And those assessment findings should support the diagnosis, right? So if it's alteration in blood gas, right? Alteration in gas exchange, they had an oxygen requirement, or you know, the oxygen on the ABG was low. Okay. Or they had cyanosis around the mouth.
Okay.
Or they were pale and they were confused. Signs of hypoxia that support the diagnosis of alteration in gas exchange.
Okay. So then you do want it like related to an evidence by, right?
Yes, I do want full NANDA diagnoses.
Awesome. Okay. All right. Thank you.
You're welcome.
Bye.
Okay, so my question is, it has to do with my patho class, and I'm a person that I kind of need feedback because I really want to be able to do well in my classes, and I feel like, you know, they are foundational, they kind of build on everything. So not getting the feedback from the quizzes and exams is hard for me because I kind of feel like I need to know what I'm missing, and so that I can understand it better so that I can move forward.
Yeah, you know, okay, one thing I'm sorry to like interrupt, but I want you to know that you don't have to score less than 80 to remediate or meet with your instructor.
That is what I am doing, but because on the exam I didn't need to remediate, but I do want to see how I'm doing on it, but she is pretty booked. So my question is, are you able to get into a test for another class?
No, I don't have access to patho. Miss Weebelhaus does.
Okay.
And yeah, if
But
an
Miss
instructor is
Weebelhaus will send me
booked-
back to Miss Arnold. So.
Okay, yeah. Okay.
I'm just
Follow up with
wondering.
Ms. Wiebelhaus. If you're still not getting time for an appointment, I would still go back to Ms. Wiebelhaus and let her know.
It's not that I'm not getting any time because
Mhm.
we had quiz back a couple of weeks ago, and I wanted to remediate for that too, just again to get the feedback so that I'm moving forward.
Yeah.
And so I have an appointment with her tomorrow for that, and I asked her if we could just cover the exam while we're at it, but she says she can't, she's booked. And I know that this test was extra hard, so I'm thinking that she's going to, where I didn't require remediation, she's probably going to want to put in the people that did require it before me, and so it's going to be a while before she's going to get to me, and by that time we're going to have another exam and
Well,
all of
hopefully
that.
not. She should, she should be able to meet with you. Yeah.
Okay.
Yeah.
So,
Unfortunately, yeah, I wish I could help you with that, but
and they've talked about how any of the instructors can tutor us, but it doesn't help if we don't know what we need tutoring in, and so that's my concern. I don't
have
know
access
exactly
to
what it
the
is.
book, so if you had a specific question about something that you wanted me to look up, I could do that.
Yeah, I don't know.
Yeah, right.
I guess I could be, I don't know, maybe she would email me with the concepts I need. I don't know. I'll work it out. I was just wondering if another instructor happened to have access to it, but if not, all right.
I don't. Yeah, we all make up our own exams, and really each instructor, we have our autonomy too. So if somebody else was meeting with one of my students talking about my exams, I would not want to have that, because I want to know what the issue, I need to know what's going on with my students, Because what if there's quite a few students that aren't understanding something? I need to know that so I can go back and reinforce that, right?
Yeah. Well, she has told us that we don't have to meet with the instructor that teaches the class to get tutoring. So kind of the same thing, but yeah, it's just the exam. I just kind of wanted to know.
Yeah, like if it's
what
blood
areas.
gas, you learn blood gas in patho also, so I could do that, or or if it was one of the disease processes,
Yeah,
but
I just need to know what it is though.
right.
So, okay.
Yeah.
All right, I appreciate it, and I'll see what I
But
can
Ms.
do from here.
Wiebelhaus does have access to the exams in her class, so
Okay.
she could go in and pull up your exam and say, actually, you answered this for this, and the correct answer was this, and here's the rationale why. She would have that.
Okay, all right.
So
I'll see what I can work out then. So, okay.
Good luck. Let me know. I can always, talk about an issue if an instructor is getting bogged down, and he's getting too overworked. We can, we could come up with a solution.
All right, sounds great. I appreciate
I do
it.
appreciate you letting me know of that. So let me know if it continues to be an issue, please.
Yeah, no problem. All right, thank you.
Thank you.
All right, have a good day.
Yep.
Bye.
Bye, thanks. Stop share. Oh, and then share here. And that's your sister. Hello?